Good morning and welcome to Northwell's fourth annual Cancer Rehabilitation Conference. My name is Tom Phillip and I'm the Senior Director for Northwell's Physical Medicine and Rehabilitation Service Line. Today we'll discuss research and recovery innovations in cancer rehabilitation. Please note that today's event is eligible for various continuing medical educational credits through Northwell's Office of Continuing Medical Education's joint accreditation. Let's take a look at some of the professions who will receive CEUs for their attendance at today's event. All in attendance will receive their attendance certificate within 7 to 10 business days after today. You will receive this certificate from Northwell's Rehab Education mailbox. We take your feedback seriously and use the information to make changes and improvements to our future events. At the end of today's conference, we'll post a SurveyMonkey link in the Zoom chat in order to collect your feedback from today's conference. You will also receive a 3-month post-activity outcome survey from Rehab Education mailbox. We really hope all of you will take a few minutes to complete both the surveys. Up on screen is Northwell's disclosure policy. This and the next slide reflects faculty and planner disclosures. It is now my honor and privilege to introduce one of our course co-directors for today, Dr. Susan Malser. Dr. Malser is the Medical Director for Northwell's Cancer Rehabilitation Program, Vice Chair for Northwell's Physical Medicine and Rehabilitation Service Line, Chair for Northwell Glen Cove Hospital's Inpatient Rehabilitation Program, and an Associate Professor at Zucker School of Medicine. Dr. Malser.
Thank you, Tom, and welcome everybody. Good morning. Thank you for joining us for our 4th annual Cancer Rehab Conference. We're so excited you're here. I hope that this conference, presenting evidence-based updates in cancer rehab, enhances our clinical care and also sparks some research ideas among the participants. I want to sincerely thank our speakers, our planning committee, and Tom Phillip and Courtney McPartland, without whom this conference simply could not be possible. I really look forward to this morning and hearing your feedback. Hey, I'm excited to present today on fractured knowledge, exercise recommendations in patients with bone metastasis. This is a subject that's very near and dear to my heart, something that I've had a lot of interest in for a long time. I'm just going to jump right into it. This slide basically shows us that we have a lot of patients with advanced cancer or metastatic cancer that have bone metastasis. And most commonly, these are going to be patients with obviously multiple myeloma, but also breast, prostate, and lung cancer. Those are probably the ones where we see bone metastasis the most. When we talk about bone metastasis and we evaluate the literature and different studies, main outcome measures for those studies are going to be something called skeletal-related events. Skeletal-related events are complications of bone metastasis, and they include things like pain, hypercalcemia, neurologic compromise, and pathologic fractures. It used to be thought that bone metastases were either osteoblastic or osteolytic, and that we only had to worry about osteolytic lesions, but not as much in osteoblastic lesions. We now know that bone metastasis is a complex genetic and biochemical process which combines osteolytic and osteoblastic components and kind of causes this vicious cycle of breaking down of healthy bone, osteolysis, and laying down of new, fragile, unstable bone, and that's the osteoblastic components. Very important when we think about bone metastasis, we have to think that even before someone's cancer became metastatic, whether they had prostate cancer or lung cancer or breast cancer, their bone health was not optimal. Patients that undergo chemotherapy have decrements in their bone. Women who undergo aromatase inhibition, men that undergo androgen deprivation therapy, their bone becomes osteoporotic, and pretty much all cancer patients take steroids, which over a long period of time can certainly cause osteopenia and osteoporosis. So when we have a patient that has bone metastasis and we evaluate them for exercise, we have to remember that even prior to having bone metastasis, they did not have healthy bone. In this article called Association of Bone Metastasis with Early Stage Breast Cancer, with and without osteoporosis, they looked at 9,000 women with breast cancer who went on to develop bone metastasis. And they wanted to see if bone metastases were associated with osteoporosis prior to the metastasis or osteoporosis medications prior to the metastasis. So what they found was that precancer osteoporosis was not associated with the risk of bone metastasis. The use of osteoporosis medications was not associated with bone metastasis, but untreated osteoporosis was associated with accelerated progression of bone metastasis. And it actually makes sense if you think about that vicious cycle we just talked about, which is the breaking down of healthy bone, osteolysis, and osteoblastic bone. If somebody has bone metastasis and they have osteoporosis, that breakdown is going to happen a lot faster. We're going to jump a little bit from bone metastasis to exercise in order to understand how we can help our patients engage in exercise safely. I want to just review some of the recommendations from the American College of Sports Medicine. And the American College of Sports Medicine's position on exercise is that exercise can be preventative in several cancers, including bladder, breast, colon, endometrial, esophageal, kidney, and stomach cancers, and may actually extend survival of 3 common cancers, such as breast, colon, and prostate. To me, that means that our patients that have cancer, prescribing exercise is like prescribing medicine, hence the term exercise is medicine. There's very strong evidence for improvements in health-related quality of life, anxiety, depression in those that exercise. And the American College of Sports Medicine recommends 150 to 300 minutes of moderate to vigorous activity a week, and 2 times weekly strength training. All of us in rehab want our patients to exercise. However, many are afraid that for patients that have bone metastasis, we're afraid that we are going to cause a fracture to happen. So let's kind of dive into quickly what criteria we can use to see whether someone is at risk for a fracture with bone metastasis. The most commonly used systems is the Merrill scoring criteria. And basically, as you can see here, it assesses somebody's risk for pathologic fracture and basically comes up with a scoring system. And if you score greater than 9, you're recommended to have prophylactic fixation. For us in rehab, we may not always have all the imaging available to us or to a physical therapist or to an exercise physiologist. But one of the biggest things that we can assess is something that's called functional pain, and that's pain with movement. So if somebody has functional pain in an area where there's a lesion, that warrants further investigating as to whether the patient is safe to exercise that part of their body. In a famous study by Bunting, he looked at 54 patients undergoing rehabilitation and noted that even though many patients went on to fracture, those fractures did not happen while in rehabilitation in therapy, but were mostly silent and mostly happened in bed. And the theory is that most of these patients are going to have a progression of their lesion. And if they're going to fracture, they're going to fracture regardless. This is a very interesting study in mice looking at what happens to bone when there is compression on it, or equivalent of resistant training on it. So they took mice and they injected metastatic breast cancer cells, and they compared the tibia of the mice, loaded and non-loaded. So you can see up on top here in the control, both loaded and non-loaded in healthy mice, there was no difference. However, in the bottom, where the tumor mice were loaded, under the tibial compression, you could see that the bone was preserved, whereas non-loaded with no tibial compression, the bone had osteolysis. So really tibial compression here prevented osteolysis. I think this is very exciting and is one of the ways we can really extrapolate to resistance training in bone metastasis. The International Bone Metastasis Exercise Working Group put out recommendations. And basically what they want is for us to do an individual risk assessment. That's their number one recommendation. And the risk assessment has to be lesion related, cancer treatment related, and patient related. So, depending on where the lesion is, number of lesions, is that lesion causing pain? What kind of cancer diagnosis does the patient have? Did they have chemotherapy? Did they have radiation? What is their prognosis? Are they in pain? Is there neurologic compromise? Are they at risk for falls? This kind of individualizes that cancer exercise prescription. That was their first recommendation. Second is to consult with the medical team. I do believe that every person who has metastatic cancer, to get an exercise prescription, should have a visit with a rehabilitation physician or a physiatrist to kind of delve into all these comorbidities that cancer patients have. And they do recommend that, especially in the beginning, that therapy be prescribed by experts such as physical therapists, exercise physiologists, and be supervised. And then again, we want to focus on postural alignment, controlled movement, proper lifting technique before they exercise on their own. In this study of 50 patients with prostate cancer, metastatic to bone, 92% were interested in completing exercise program, but only 29% were able to complete. And the barriers were fatigue, pain, but also referrals to such exercise programs. Those that were able to exercise had higher physical functioning scores and quality of life scores. So we know our patients want to exercise. It's kind of on us to provide them with the methods to do so. Looking here and in that study, when we look at the clinical characteristics of those that were able to exercise or not able to exercise, it's interesting to see that some things that we think would make a difference didn't. So for example, age was about the same. Time since cancer diagnosis doesn't seem to make any difference. Those that were meeting aerobic exercise were further out from their cancer diagnosis. What really does make a big difference is the number of lesions and the severity of metastatic disease. So you can see here that most people that had major bone metastatic disease with more than 2 regions affected, those are the people not meeting the exercise guidelines. So, one way to say is those that have more advanced disease are not able to exercise, and how can we target those populations? This is just a systematic review looking at the safety of exercise in patients with bone metastasis. In 17 trials that they looked at, they were very few serious adverse events. None of them resulted in fractures. And again, those patients were able to get the benefits of exercise. This is probably my favorite study looking at exercise in patients with bone metastasis. They took 60 patients and they randomized them to two groups, aerobic exercise and aerobic and resistance exercise. What's cool about this study is that they gave patients exercises that targeted the area where they had bone metastasis. So patients were undergoing radiation, let's say to the area of L3, and that is the area where they had exercises. So for example, to their paravertebral muscles. And they wanted to see what happens when you exercise a specific area with the lesion to that bone. And what they found was that those that were in the resistance exercise group, not just the aerobic group, but they had a significantly increased bone density in the lesion where the bone metastases were. So the vertebral body that had bone metastasis actually increased bone density. This is very exciting that, you know, they were able to do this without causing any fractures. Here's another study. They did things a little bit differently. They excluded the part of the body that had bone metastasis. So if you have metastasis in your trunk, you exercise your upper and lower body. If you had metastasis in your hip, you did your trunk and your upper body. And again, they had no fracture, no complications. I found this study very interesting. Another study looking at resistance training during radiation. And basically, the resistance training group was one half. The other group was just passive physical therapy that was mainly aerobic. And both groups had no difference in progression of disease or survival. However, the group that had resistance training had less local bone progression in the area that they had radiation. So the lesion that was targeted with radiation had less progression of disease in the resistance training group. So again, to me, this is exercise is medicine. Another interesting study looking at patients with metastatic disease and exercise. Interestingly here, 73% of 58 patients led very sedentary lifestyle, and sedentary lifestyle correlated with past fracture risk. So anybody that had a previous fracture was found to be more sedentary, and only 28 patients in the study were able to complete more than 150 minutes a week of moderate intensity exercise. Those patients had no fractures. They were able to do it safely. However, this just shows that, you know, of a large cohort of patients, only, you know, little more than half were able to complete their exercise recommendations. Here's another study looking at exercise in bone metastasis patients. Again, this study chose to exclude areas with metastatic disease and only focus on parts of the body that did not have active disease. What I found interesting here was that overall physical functioning improved in the patients that had exercise versus controls. But what improved the most was, in this study, leg extension. So you could see here that in the exercise group, in kilograms, leg extension went from 60 to 65, whereas in the control group, it kind of stayed at baseline. In this study, all the other tests, such as up and go, 6-minute walk, stayed about the same. Once again, what was interesting with this study was that even though these were fairly sick patients undergoing radiation, none of them developed any fractures and any adverse events. This concludes my talk. I hope that this sparked your interest in exercise and patients with metastatic disease. And I just want to say that there are not a lot of studies done on patients with bone metastasis and exercise. And so I really think that there's a lot of opportunities to do some and to learn more about this topic. Now it gives me great pleasure to introduce my course co-director, Dr. Patrick Martone. He's the medical director of cancer rehab medicine for the Eastern region at Northwell Health. He's our fellowship program director. He's assistant professor of physical medicine and rehabilitation at the Zucker School of Medicine. And I can't wait to hear his talk.
Hi, everyone. It's my honor and privilege to be here with you today. My name is Patrick Martone, and I am the Fellowship Program Director for Cancer Rehabilitation Medicine at Northwell Health Zucker School of Medicine. Today, I'm going to speak to you about chemotherapy-induced peripheral neuropathy, preferential treatments and interventions for this in a guideline-based manner. When we talk about chemotherapy-induced peripheral neuropathy, this is unfortunately very common in cancer survivors. Up to 40% across the board of cancer survivors will experience chemotherapy neuropathy symptoms. And so this can not only impact patients' function, but it can also cause discomfort. Certainly neuropathic symptoms can cause difficulty with performing ADLs, difficulty with things like balance, and it also can cause pain. And so for those reasons, we want to be aware of these symptoms and do things to help treat and mitigate them. Specifically, when we are looking at agents that cause chemotherapy-induced peripheral neuropathy, there are unfortunately many culprits, certainly taxanes, carboplatinums, vinca alkaloids, and all of these can certainly impact the nervous system through different mechanisms at different parts of the nervous system. So now let's discuss potential treatments that we can utilize for chemotherapy-induced peripheral neuropathy. There's certainly many avenues that we can go and different treatments we can choose from. There's pharmacologic interventions. Classically, we think of things like SNRIs, anticonvulsant medications, neuropathic pain agents. There's non-pharmacologic treatments, things like cryotherapy, scrambler therapy, modalities of exercise. And then there's integrative things such as topical creams or acupuncture. So certainly lots of things that we can utilize and look at for prevention and treatment of neuropathy to consider. So when we talk about chemotherapy-induced peripheral neuropathy, we really want to look at it in two forms. One is there anything that we can do to prevent these symptoms, to prevent them from occurring, to prevent patients from getting them or developing them? And secondly, if patients do develop them, how do we manage those symptoms? And so ASCO specifically released guidelines in 2020 on the most up-to-date guidelines on what we can do for both prevention and management of chemotherapy neuropathy. When we look in terms of prevention, so what can we do to prevent patients from developing neuropathy? What can we do to prevent patients from developing neuropathy? Lots of things were looked at and the research behind lots of things, meaning medications, supplements, different physical modalities. Essentially, for prevention, with this up-to-date guideline, outside of the context of clinical trial, no recommendation can be made for the prevention of neuropathy in relation to acupuncture, cryotherapy, compression therapy, or exercise therapy. Now, while they say no recommendation can be made for it, when we look at those modalities, it's important to understand that there's a lot of modalities where they actually recommend strength against utilizing those modalities. So certainly these are potentially things that if we collect more data can potentially be useful for prevention. So we were talking about prevention, but what happens when patients actually do develop neuropathy symptoms? What are we doing for the management of these symptoms of neuropathy? What are we doing for the treatment of them? So again, according to these guidelines, for patients who do develop painful symptoms of chemotherapy-induced neuropathy, certainly we can offer duloxetine. So that has been studied with evidence to be beneficial for patients with painful chemotherapy-induced peripheral neuropathy. And then looking at other potential modalities that we can utilize, again, without in the context of a clinical trial, no recommendation can be made for exercise, acupuncture, scrambler therapy, gabapentin pregabalin, topical gels, tricyclic antidepressants, or oral cannabinoids. But certainly, again, as we are going through all of this, we're going to demonstrate and have you see more and more studies that might be helpful for us to eventually, ultimately have that strength of evidence. So let's dive into some of the more specifics, and we're going to start with prevention, so things that can help to prevent chemotherapy-induced neuropathy. So first, let's look at cryotherapy. So cryotherapy is actually using cooling agents in your fingers and your toes, making them cold during chemotherapy to hopefully prevent developing those neuropathy symptoms. So this is a recent trial looking specifically in gynecologic cancers receiving taxane-based chemotherapy. So again, taxane-based therapies, very common to be causing neuropathies. And they performed cryotherapy and then what's called cryocompression, where they actually did compression on those extremities with adding the cold. They started that 30 minutes before, had them doing it during, and then remained 30 minutes after that chemotherapy administration. So what they found in this study was that the intervention group, so patients that received that cryotherapy, so cooling of those extremities, as well as those who had cryocompression, so cooling with actually adding that compression, had less significant episodes of chemotherapy-induced peripheral neuropathy. As you look here, standard after taxane treatment, as high as studies have shown 87% of patients can develop neuropathy symptoms. In this study, where patients had the cryotherapy or cryocompression, 13.7% and 17.2% developed that significant grade 2 chemotherapy-induced peripheral neuropathy. So again, these are promising things that may potentially, as we get more evidence, be useful for prevention of chemotherapy-induced peripheral neuropathy. So this is a very interesting study that I was happy to come across. So typically, as I said, we typically think of duloxetine as being something that's well studied, well utilized in the management of neuropathy symptoms from chemotherapy, so in treating those symptoms that have already developed. But this specifically was a study looking at, is duloxetine effective at preventing those neuropathy symptoms? Can it be used as a preventative modality? So this study was looked at using duloxetine in gastrointestinal cancers receiving oxaliplatin-induced neuropathies. So again, oxaliplatin, part of that platinum group, very common to develop neuropathies. And so what they did is these patients who were undergoing that chemotherapy, they were started on duloxetine the day before chemotherapy at 30 milligrams for 1 week daily. And then this was titrated up to 60 milligrams daily for 12 weeks. And they compared this to the placebo group. I think it's important to understand a little bit of the exclusion criteria, because I think that this can give you a little bit of knowledge of when you maybe wouldn't want to utilize duloxetine, even if you're using it not for prevention, but for management of neuropathy. Exclusion criteria were uncontrolled hypertension, creatinine clearance less than 30, so always looking at what is their kidney function, what is their creatinine clearance, liver impairment, so significantly elevated AST or LST greater than 3 times the upper normal level of limit, so always looking, do they have any liver impairment or do they have liver metastasis? Those are reasons why we might not want to utilize duloxetine in our cancer patients. So still in the light of looking at prevention for developing neuropathy, exercise is certainly something that there's more and more evidence for being helpful for not only the treatment of neuropathy, but also potentially prevention. So this was a pretty large trial, 355 patients, again, undergoing those typical agents that cause neuropathy, taxanes, platinums, vinca alkaloids. And so they had two groups. They had the standard of care group, which is essentially let's not do any exercise, not promote that activity. And then they had the exercise group, or the XCAP group, it's called. And so I'd like to actually go into a little bit of what that exercise group actually was doing, because I think that's important for us, especially working in rehabilitation, that we understand how are we counseling our patients to do these studied exercise protocols. So part of that XCAP, which means the intervention group, was there was an aspect of aerobic activity. So they did low to moderate intensity aerobic activity daily. And basically they did this by using steps and step counting. And so basically they had people increase their number of steps by 5 to 20% of steps per week. And that's how they got that aerobic activity. And then there was also a resistance component where they did low to moderate intensity resistance exercises. And so basically they taught them 10 exercises with resistance bands. Again, nothing too fancy that we couldn't emulate in any of our centers or teaching our patients. And essentially those exercises involve doing squats, side bends, leg extensions, leg curls, tricep extensions, chest press, rows, calf raises, overhead press, and biceps curls. So basically doing the major muscle groups of your body with those resistance bands, a maximum of 4 sets at 15 repetitions. So that is what that intervention group was doing, and certainly this is something very feasible that we could be training and teaching our patients. And so when they actually looked at this XCAP group, this exercise intervention group undergoing chemotherapy versus the standard of care or control group who wasn't exercising, they did find that exercise did have some benefit in reducing chemotherapy neuropathy symptoms, specifically in relation to sensation of hot and cold disruption, and numbness and tingling in the hands and feet. So certainly exercise is something that, for multiple reasons, we want to be educating and treating our patients for, but certainly potentially can be helpful in preventing chemotherapy-induced neuropathy symptoms. Now let's look how acupuncture could potentially play a role in preventing chemotherapy-induced neuropathy. So this is a study looking at breast cancer patients receiving either neoadjuvant or adjuvant weekly paclitaxel. And so the goal of this study was to look at patients undergoing this chemotherapy who were developing neuropathy symptoms of grade 2 to see if they could prevent escalation to higher grades. And so why this is important is because when patients develop these neuropathy symptoms, this can be dose limiting, meaning that these patients cannot potentially complete treatment or cannot complete an appropriate amount of treatment because of these rate limiting side effects. So again, this looked at, can acupuncture prevent that escalation of these neuropathy symptoms? And so essentially these patients who were developing these symptoms had acupuncture performed on them for about 30 minutes, where they, after they receive that dai chi sensation. So that's essentially this aching in the musculature that can occur after placing needles. So in this study, these are actually the types of acupuncture points that they utilized. Certainly in my practice, I will utilize this in a lot of my neuropathy patients. These are points that are very helpful, especially in the areas of the limbs where we see chemotherapy-induced peripheral neuropathy to help potentially with these symptoms. So the results of this study, while it was small, 26 out of 27 of those patients receiving the acupuncture treatment were able to complete that paclitaxel treatment without developing grade 3 chemotherapy-induced peripheral neuropathy. So again, the potential significance of this is that acupuncture could potentially be utilized to prevent progression of those symptoms and to prevent dose-limiting symptoms of neuropathy in our patients. The underlying mechanism for why potentially acupuncture may be helpful is that because when we produce that dai chi sensation, so that muscle ache with the needling, and we're stimulating these meridians, these pathways within the body, that actually may be having impact on our alpha delta and our C fibers. The C fibers especially, you're going to see again here that they can be utilized to target in neuropathy symptoms with other modalities. So the last potential mechanism we can use for prevention in chemotherapy-induced neuropathy is medical cannabis. So medical cannabis, typically it's the CBD when we think about cannabis in helping with neuropathy and chemotherapy-induced neuropathy symptoms. So cannabis, the way that we think that this works is that it hits CB1 and CB2 receptors. CB1 type receptors actually can, we think, help prevent hyperexcitability of neurons. And then CB2 reactors can actually decrease inflammation, decrease this pro-inflammatory state that can happen in pain, especially with neuropathy. So this was a recent study in which they used cannabis and CBD in identifying if that can prevent neuropathy in patients receiving carboplatin and paclitaxel or capecitabine and oxaliplatin versus a control group. And so what they did was they used 150 milligrams of CBD administered twice daily before chemotherapy and then continued it for 7 days after. They found that in the CBD group, they had less cold sensitivity, less throat discomfort, and less discomfort with swallowing cold liquids. So certainly, again, a potential mechanism that may in the future have more evidence for preventing neuropathy symptoms. Okay, so now let's switch gears. We were talking about prevention of chemotherapy-induced neuropathy. Now let's talk about the management. How do we treat it when symptoms develop? So again, there's pharmacological means that we can help it. Again, mostly we think of SNRIs such as duloxetine or anticonvulsant or calcium channel blockers such as pregabalin. So we did state that, duloxetine does have a moderate recommendation for the use in management and certainly has been studied. This specifically was a newer study comparing the effectiveness of duloxetine versus pregabalin. And so, the overall take from this is that they actually did both produce a decrease in pain symptoms in patients after a month of use. So duloxetine, they use a protocol of 30 milligrams daily for 1 week and then 30 milligrams twice daily for 3 weeks. The pregabalin, they use 75 milligrams daily for 1 week, then 70 milligrams twice daily for 3 weeks. And so the duloxetine did have more improvement, but the pregabalin also had improvement. So I think that's important to recognize that, especially if you have side effects or you have reasons why you wouldn't want to use duloxetine, you can potentially use pregabalin for management. We talked previously about how exercise could potentially be used for prevention of neuropathy, but can exercise be used to help manage the symptoms of neuropathy? And so this was a more recent systemic review of exercise modalities in chemotherapy-induced peripheral neuropathy. So in the systemic review, they looked at different exercise modalities and how that impacted symptoms of neuropathy, looking at aerobic exercises versus balance exercises, strength training, yoga. One important thing is that, again, they found that no severe adverse effects were found in these patients, which again is important overall because exercise is so important in cancer care now. We want to be promoting it, and exercise is safe in cancer patients. An important thing to recognize is that balance and strength training actually showed the most significant improvement in quality of life scores. So again, maybe this one we're educating about exercise, specifically in neuropathy, we want to be focusing more on that balance and strength training in those patients. Something that potentially can be very promising for the management as well of neuropathy symptoms is what's called scrambler therapy. And so scrambler therapy is essentially, it's a non-invasive tool using electrodes and electropads to, again, stimulate those C fibers. So like we saw with CBD potentially impacting C fibers, scrambler therapy can also do this. And essentially with scrambler therapy, the theory is that it can inhibit those C fibers and recode them so they're not generating so much pain sensation. And so this was a study actually looking at scrambler therapy versus TENS unit in peripheral neuropathy and was a crossover trial. And in looking at the results of this, both were helpful, but scrambler therapy was overall more helpful in these symptoms of global sensation or changes in neuropathy symptoms, changes in pain, and overall changes of quality of life. And lastly, and very quickly, I did want to broach the topic of topical creams and treatments and potential more natural remedies that can be utilized for symptom management. Certainly there are reviews out there looking at these things such as menthol and other modalities. Again, still something to be studied, but potentially an option for our patients, especially those who do not want pharmacologic management. So just to kind of recap and summarize, according to specific guidelines, we don't have sufficient evidence for a lot of these things that we are utilizing to treat our patients. But certainly as we see from the timing of those guidelines to even now, more and more trials and studies are coming out that show that these modalities, these pharmacologic interventions, these natural or integrative techniques can be useful in possibly preventing and managing these neuropathy symptoms. So I want to thank you very much for having me for this talk, and please feel free to reach out with any questions you may have.
Thank you, Dr. Martone. Let's now bring in Marissa Prasano, who is an occupational therapist with Northwell's Outpatient Therapy Network. Marissa is a certified lymphedema therapist, and today she will discuss with us the role of exercise for management of breast cancer-related lymphedema. Marissa, take it away, please.
Hi, everybody. My name is Marissa. I'm an occupational therapist and certified lymphedema therapist, currently working within the NISMAT team at Meath. Today's talk is going to be about the role of exercise for management of breast cancer-related lymphedema. At Meath, I do see all types of lymphedema patients, whether they're breast, arm, leg, head and neck, but today's focus is going to be on breast cancer. So today's objectives, we're just going to do a really brief overview of lymphedema. I'm sure a lot of you already have some knowledge in that area, but I just wanted to go over it briefly. We're going to review the conventional lymphedema treatment from the OT-PT perspective, so what I do in therapy. We're going to review the incidence of breast cancer-related lymphedema, past assumptions regarding exercise and lymphedema, current research related to lymphedema prevention and the management for breast cancer-related lymphedema. We're going to review some considerations for exercise prescription, so what you might be able to tell your patients, or and review what I would go over with my patients as well. I'm also going to show you some common exercises that I prescribe to my patients in the clinic, and then we'll review some current exercise programs that are designed for cancer survivors. So for our lymphedema overview, there are two types of lymphedema, primary and secondary lymphedema. Primary lymphedema is more of your congenital types. So you are born with a not intact lymphatic system. There are several different types, but for today's purposes, we're going to be focusing on secondary lymphedema, which occurs due to a disruption in the lymphatics, such as lymph node removal during surgery. Lymphedema itself is a buildup of protein-rich fluid in the interstitium due to obstructed, damaged, or removed lymphatics, such as lymph nodes. The result is swelling of the affected region. Currently, there is no quote-unquote cure. There are some surgical techniques out there now. However, it is not technically considered a cure for lymphedema. Lymphedema is chronic. It's progressive unless it's managed correctly. So a brief overview of lymphedema therapy and what I do in the clinic with my patients. Traditional lymphedema therapy has 4 key components: compression, manual lymphatic drainage, patient education involving skincare and lymphedema risk precautions, and exercise. Within compression, there are 2 phases: decongestive and maintenance. Depending on the staging of the patient's lymphedema or the appearance of the limb that's effective, they may or may not have to go through the decongestive phase. If they do require decongestion, typically the gold standard is multi-layer bandaging. The photo is on the screen here that you can see. It's a fairly intensive phase where the patient needs to be bandaged as close to 23 out of 24 hours a day in order to really reduce the size of the limb. Once the patient gets through the decongestive phase, then we measure them for compression garments to help maintain them at that level. There are daytime and nighttime compression garments out there. It's very important that patients are compliant with their compression, because otherwise the lymphedema will come back or, continue to progress without the compression. As I said earlier, we're going to be focusing on the exercise component. Before we get into talking about the research and exercise itself, I just wanted to briefly go over breast cancer-related lymphedema incidence. It does vary quite a bit in the literature, anywhere from 10 to 65%. This is likely due to the fact that there isn't really a gold standard of measurement for lymphedema out there. There are varying modes of measurement. There are varying definitions of statistically significant lymphedema, so that definitely affects how the incidence is reported. There are several risk factors that are shown to increase the likelihood of developing lymphedema, including type of surgery, so axillary lymph node dissection versus sentinel lymph node biopsy, the radiation field, the dose and the area irradiated, and BMI. So let's get into a little bit of the past assumptions related to exercise and lymphedema. Previously, there was a fear that exercise would place excess stress on an already stressed lymphatic system. So if somebody has an axillary lymph node dissection but didn't necessarily develop lymphedema yet, there was some concern that with exercise, we would put added stress to an already stressed lymphatic system and basically would cause the lymphatic system to have to work harder, potentially triggering lymphedema. The recommendation at that time was to avoid any strenuous activity with the affected arm. The more recent thought and what the more recent research is showing is that actually deconditioning could lead to excess strain on the lymphatic system when activity does occur. We can't avoid activity, especially our arms. We use our arms for everything, so it's pretty unrealistic that we could avoid doing anything strenuous with our arms. Activity can be defined as something as simple as carrying grocery bags in from your car or carrying laundry basket up the stairs. So if you're not exercising and you're deconditioned, once you go and try and lift those grocery bags, that is what's actually placing more stress on the lymphatic system, because your body isn't used to that anymore because you haven't been using it. So the first study we're going to go over is looking at exercise and breast cancer-related lymphedema prevention. So this study was done in 2019. So a randomized controlled trial to determine if progressive resistance exercise, or PRE, could prevent onset of breast cancer-related lymphedema 1 year after treatment. This was done in Denmark. They took 643 women with unilateral breast cancer undergoing axillary lymph node dissection. They were taken from 3 different hospitals. Ages varied between 18 to 75. Aside from surgery, radiation and chemotherapy were provided to the patient based on their specific needs. This is something to think about when it comes to the results, as treatments such as radiation and certain chemotherapies can increase your risk for lymphedema. So just something to keep in mind. All of these patients were assessed by trained PTs and OTs for baseline 4 weeks post-op surgery. The primary outcome measures were arm volume via water displacement, subjective symptoms of lymphedema, strength, range of motion. The interlimb volume difference was considered to be greater than 3%, and that's what they noted as considered to be lymphedema. The interlimb volume difference in the study is an example of the varying definitions of lymphedema, as other literature notes that anything 200 milliliters or more, or 10% more, is what's considered as statistically significant lymphedema. This study is using anything over 3%. So again, just something to keep in mind. There were 2 groups in this study. The first group was the exercise intervention group, and the second group was usual care. Usual care is defined as the patients were free to exercise without any restriction, and it wasn't supervised. For the intervention group, there were 2 phases. Phase 1 was 20 weeks, phase 2 was 30 weeks. For phase 1, there were supervised and home exercises. For phase 2, there were only home exercises 3 times a week. For the first phase, baseline was determined by maximum weight for 7 reps and then safely progressed each month based on the PT or OT's tests. The intensity initially was less than 60% of a 1 rep max. After week 12, the loads lifted to fatigue. The focus was on major muscle groups, including the upper extremities, core, and lower extremities. During phase 2, with the home exercises 3 times a week, a person's symptoms were evaluated using a numerical rating scale from a scale of 0 to 10. What was being focused on was a person's report of limb heaviness, tightness, or swelling. These are all fairly common subjective reports by patients during the very early stages of lymphedema, so that's what was used. The assessment was interlimb volume differences measured at 12 and 20 weeks. And the response to symptoms were that if there was a 2-point increase in symptoms, the participants received a compression sleeve and referred to a lymphedema therapist. And they had to postpone exercise progression until stable for at least 2 weeks. During the second phase, the patients were allowed to choose their exercises. The results at the end of the study were that both groups experienced increased interlimb volume difference and self-reported swelling/tension over 12 months. The control group had a decrease in interlimb mass difference, while the intervention group saw an increase. There was no significant differences in interlimb volume, self-reported swelling, or the greater than 3% increase in interlimb volume difference between the groups at 12 months. The intervention group did show an increase in strength with no significant differences in terms of range of motion. Something to think about for the results was the interlimb volume difference was higher in the intervention group. However, the technique that they used to assess this was water displacement. Water displacement cannot distinguish between fluid from other tissue, such as muscle. So the fact that the intervention group also had an increase in strength may have some influence on this. Bioimpedance probably would have been a more accurate assessment tool to use because it uses the electrical current to measure impedance, such as the SOZO, which I'm sure some of you are familiar with. Overall, there was no significant differences in terms of prevention for the exercise group versus the control group. Overall, the key takeaway was exercise is safe for high-risk individuals, but it did not demonstrate a preventative effect. The next study that we're going to look at is going to focus more on the management aspect of breast cancer-related lymphedema and exercise versus the preventative effect. This study was a systematic review and update and meta-analysis done in 2020. The goal was to analyze resistance exercise and its effects on breast cancer-related lymphedema. What makes this different from a past meta-analysis? They're looking at studies with homogeneous assessment measures. This study highlighted how over the past 15 plus years, there have been multiple systemic reviews confirming that exercise is safe for breast cancer-related patients and agreement that breast cancer survivors benefit from exercise to improve and maintain physical function, promote healthy body composition, and reduce metabolic risk. These reviews have looked at studies with varying assessment measures for lymphedema. So again, the goal of this systemic review and meta-analysis was to look at the most consistent and accurate data. For the meta-analysis, they were able to pull 6 of 29 articles from the systemic review. All 6 articles followed or exceeded ACSM recommendations for resistance exercises. They provided LDEX scores via bioimpedance. They were randomized controlled or unrandomized controlled trials, and they all focused on breast cancer-related lymphedema. All articles were from 2017 or later, as this was when the last systemic review / meta-analysis ended. As with other studies, there were varying definitions of lymphedema, and there were varying degrees of treatment, whether that be chemo, radiation, and these studies did not necessarily differentiate between surgery types, such as axillary lymph node dissection or sentinel lymph node biopsy. This could be a factor in terms of the effectiveness of resistance exercises, so just something to keep in mind. The consensus of the meta-analysis was that resistance exercise does not have a systemic negative impact on breast cancer-related lymphedema. There were some studies that demonstrated potential to reduce lymphedema severity / impact on quality of life and functional performance. The key takeaways of this meta-analysis were that lymphedema must be monitored if a patient is participating in resistance exercise so that lymphedema is not exacerbated or injury does not occur. Appropriate intervention should be recommended in combination with exercise, such as compression garments, manual lymphatic drainage, compression pumps, skincare education, sort of all the traditional things that we do in lymphedema therapy. Exercise should be supervised by either an OT, a PT, or a cancer exercise specialist initially, just to make sure that the patient is performing the exercises safely and, that they get any modifications that they might need for the exercises. And there needs to be some tailoring based on the patient's needs. So it kind of goes back to some patients following surgery, radiation, chemo have different abilities in terms of their range of motion, strength, fatigue levels. So it's important that the exercises are tailored so that the patient can be successful. For the future, in terms of studies, I think there needs to be a little bit more distinction between types of surgeries, types of resistance exercises, intensities of resistance exercises, duration of exercises, just to make things a little bit more accurate. I do like this study because it did look at more studies that were assessing lymphedema with the same sort of measure, such as the SOZO. So I think that was a good step in the right direction. So how do we prescribe our patients exercise? I wanted to share a study that I found that looked at various exercise modes. This was done in 2024. The 4 exercise modes looked at were yoga, resistance exercise, water-based exercise, and complex exercise. So it was a combination of both resistance exercise and aerobic exercise. It was a systemic review of 13 randomized controlled trials, and the goal was to provide recommendations for exercise prescription for breast cancer-related lymphedema with the goal of reducing severity of symptoms. Just as with the other studies, something to keep in mind or a limiting factor was the different modes of lymphedema assessment and definition and different timelines and durations of exercises used or the exercise protocols. The supervision levels also varied, and some were home programs. So just something to keep in mind for this study. Following the systemic review, the key takeaways they found were that resistance exercise and yoga demonstrated the most significant reduction in severity. High frequency exercise, such as daily exercise, may be best. Exercise should be long-term, as progress may not be maintained, which is something I tell all of my patients, that they need to keep up with all of their exercises once they're done with therapy with me, and that supervision may not be necessary. As I said a couple of slides ago, my opinion is that at least in the beginning, there should be some level of supervision just to help prevent any injuries or lymphedema exacerbation or provide any modifications that a patient may need. Overall, these studies have found that exercise is safe for these patients. As I sort of said in a few of these slides, there definitely needs to be a little bit more focus on determining how to exactly define lymphedema, the best measurement for lymphedema. I think right now the best measurement is probably bioimpedance, but not all of these studies are using that. So it makes it very difficult to sort of look at any of these results because there are so many different assessment tools being used, definitions of lymphedema. We're also not breaking groups into different stages of lymphedema, different surgeries, such as the axillary lymph node dissections or sentinel lymph node biopsies. We're not really taking into consideration if the patient has had radiation therapy, chemotherapy, what kind of chemotherapy. So, those all can definitely influence a person's risk for lymphedema, how severe their lymphedema is, and the effect of exercise on their lymphedema. So in future research, I think this all needs to be looked at a little bit more closely and divided out a little bit more. But overall, we can safely say that exercise is safe, appropriate, and beneficial for these patients. So the next few slides are just some exercises that I typically prescribe to my patients. They may need to be modified based on the patient's abilities, but these are some pretty common ones. We have some seated exercises, standing exercises, and supine exercises that I'm going to show you. This first set are some seated exercises, just some shoulder rolls, scap retraction, some upper trap stretching, just to help with posture, scapular mobility, and any neck or shoulder tension that a patient may be experiencing following their surgery, radiation, or chemotherapy.
Over here. So you have some room. You have a knee.
These next set of exercises are standing, shoulder flexion wall slides, shoulder abduction wall slides, and a pec stretch. These exercises are focused on shoulder mobility, increasing pec mobility, which is a pretty big problem with most of the patients I see. Helps assist with posture, shoulder range of motion, and just that general sort of hunched over, pulling in feeling that a lot of patients feel after surgery or radiation. The goal with these exercises is to move slowly. It's advised that patients hold for at least 10 seconds when performing these exercises. And I always tell my patients it's not about how fast you can get done. You want to do these slowly and safely. And these last set of exercises are supine exercises, again, focusing on shoulder range of motion, and pec stretching, and scapular mobility and stabilization. They can use a towel, they can use a cane, they can use a long umbrella. I typically recommend that when a patient is laying flat on their back and performing these exercises, that their knees are bent up so their feet are flat on the mat or the bed that they're on, just to help protect their back. Again, these exercises should be done slowly, holding 5 to 10 seconds at a time. The model in my videos is working a little bit quickly. So again, just emphasizing that that slowness, that control. Finally, I just wanted to go over some oncology-specific exercise programs. Some of these may be familiar to you. You may already prescribe some of these programs to your patients. The first one is the Maple Tree Cancer Alliance. I know some of you already tell your patients to join this program. I just recently learned about it since I started at Northwell, and I think it's a really great program to help take patients through various stretches and strengthening exercises with a real-life cancer exercise specialist. So if a patient can't get in to see a PT or OT, I think this is a really good tool to have, because it can be done virtually. I believe they do have some on-site locations. I'm not sure if they have any in New York, but any patient I've had that has done the virtual sessions with these trainers has had a good experience. The other one is the Strength After Breast Cancer program, or the Strength ABCs. This is more of a training for therapists or exercise specialists to get. It runs through a series of exercises to take patients through in person during sessions, and then an eventual progression to a home exercise program. The exercise specialist or therapist, PT or OT, does need to get trained in Strength ABCs through close training, and then they're able to implement this with their patients. It can be used as a billable intervention. So typically the way in therapy that it would be used would be we would see them for their course of care, doing manual therapy, exercise, etc. Once they achieve most of their goals, then we sort of transition their sessions to these exercise sessions where Strength ABC sort of has a delineated program for each session, again, eventually progressing to a home program. So it's another really good tool and resource to have for therapists and exercise specialists. These are my references for all the studies that we discussed. And thank you for listening to my presentation. I hope you found it somewhat helpful. If you ever have any questions for me, or if your patients ever have any questions that you want to relay by me, feel free to reach out to me via my email that's on the screen. If you feel like any patients need a referral to therapy, can send them on my way. I am located within the NISMAT team at Meath. Our phone number is 212-434-2700. All they need is a prescription for occupational therapy, because I am an occupational therapist. So as long as they call and they have a prescription, we can get them in for an evaluation so that I can see them.
Thank you, Marissa. Let's now bring in Dr. Elisa Alpert, who is a physiatrist with Northwell Health and specializes in cancer rehabilitation. Dr. Alpert is also an assistant professor with Sucker School of Medicine. She will discuss prevention and early detection when it comes to breast cancer-related lymphedema.
Hi, I'm Lisa Alpert, and today we will be discussing advances in breast cancer lymphedema. We will be reviewing the article, Advances in the Prevention and Treatment of Breast Cancer-Related Lymphedema, published in 2023 by Paula Donahue et al. While lymphedema can be primary or secondary, we will be discussing secondary lymphedema from breast cancer treatment. While it is not life-threatening, it can affect quality of life through its impact on function, risk for infections, and emotional well-being. Although symptoms are chronic and progressive, the goal of treatment is to prevent or slow progression and prevent secondary complications. The most effective way to do this is through early diagnosis and treatment. So how do we identify and diagnose early? First, we have to define how we measure lymphedema. Lymphedema assessment is not standardized. It includes many different measurement techniques, including circumferential measurements, water displacement, bioimpedance spectroscopy, and the many others listed here. Because there are many different techniques, each method has its own advantages and disadvantages. Commonly used techniques include circumferential measurement, which is simple and economical and can be used to monitor disease progression. However, it is not precise and has moderate inter- and intra-operator variability. Bioimpedance spectroscopy is rapid and painless, has repeatable results, however can be more expensive and has limited use for bilateral symptoms. It can be used for lymphedema surveillance due to early detection. Because measurement techniques and thresholds vary, prevalence estimates are also variable. It is estimated that 1 million patients are affected by breast cancer lymphedema in the United States, which is almost 1/4 of breast cancer survivors. This literature review, published in 2022, summarizes data of the PREVENT trial with a 3-year follow-up. This demonstrated an absolute reduction of 11.3% and relative reduction of 59% in chronic breast cancer-related lymphedema using bioimpedance versus tape measurement. Patients should be measured prior to treatment and then have repeat measurements every 3 months for the first 3 years, followed by every 6 months for years 4 and 5. The target intervention is a change of LDEX score of 6.5. Risk factors for lymphedema. The primary risk factor is removal of lymph nodes. The more lymph nodes removed, the higher the risk. Therefore, axillary lymph node dissection has higher risk than sentinel lymph node dissection. Patients were found to have rates of lymphedema of 24.9% after an axillary lymph node dissection and about 8% in sentinel lymph node dissection. Mastectomy patients have higher risk than lumpectomy, and it is suggested that an immediate reconstruction lowers the risk of lymphedema. Therefore, sentinel lymph node dissection is standard of care in early breast cancer. Radiation therapy can also increase the risk, and patients with breast-conserving surgery and adjuvant systemic therapy found that patients with radiation had rates of lymphedema of 8.4%, while patients without radiation had rates of 4.5% at 9.5 years. Other proposed risk factors include age, BMI, infections, ethnicity, and subclinical lymphedema. So we've talked about what lymphedema is and how to identify it and risk factors, but how is it treated and how can it be prevented either surgically or non-surgically? Non-surgical prevention involves early surveillance to allow for early intervention. Monitoring with bioimpedance spectroscopy is recommended pre-surgically or within 90 days, and patients who began surveillance 2 years post-op versus within the first 90 days had higher rates of lymphedema of 39% compared to 14%. Bioimpedance can identify patients more likely to benefit from early compression. An early intervention of subclinical lymphedema leads to lower rates of progression to clinical lymphedema. In addition to taking bioimpedance spectroscopy measurements, early evaluation can provide patient education to inform patients on symptoms to look out for, which may lead to earlier presentation when symptoms do occur. Patients should be aware of prodromal symptoms such as achiness, heaviness, in addition to swelling. Preventative surgical techniques have been shown to reduce lymphedema rates. Axillary reverse mapping, or ARM, is one technique in which dye is used to identify and spare lymphatic drainage pathways. In a large prospective study, lymphedema rates after ARM were reduced to 0.8% in sentinel node patients and 6.5% in patients who underwent axillary lymph node dissection. LYMPHA is lymphatic microsurgical preventative healing techniques, which is done at the time of axillary dissection, in which a venous anastomosis is created connecting lymphatics to the axillary venous system. This is shown to reduce rates dramatically from 30% down to 4.3%. However, it requires experience in super microsurgery, coordination between the breast and plastic surgeon, and it has to be planned in advance. According to a study from 2021, 85% of breast surgeons do not offer a LYMPHA procedure. S-LYMPHA is a simplified version which reduces rates of lymphedema from 32% to 16%, however, may be more accessible compared to LYMPHA. And now we will discuss current treatments of breast cancer-related lymphedema. So first, no medications have been proven effective to treat or prevent lymphedema. Some medications that have been studied include ketoprofen, which has been studied in an open label exploratory and then a randomized double-blind placebo-controlled trial. And skin thickness was reduced, but there was no change in limb volume. LYT-100 was studied in a randomized double-blind placebo-controlled trial in patients with stage 1 or 2 breast cancer-related lymphedema, and medication was well tolerated. However, further results were not yet reported. Lymphactin is another medication that was studied in a double-blind randomized placebo-controlled trial. However, results were inconclusive. Tacrolimus, a single-arm study of tacrolimus ointment was done and results were not yet reported. And in one medication, QBX258, a single-arm study of anti-IL-4 and anti-IL-13 blockade, arm volume was actually significantly increased compared to baseline. Standard of care treatment involves an initial phase, or phase 1, which includes complete decongestive therapy followed by a maintenance phase, phase 2. Complete decongestive therapy includes manual lymphatic drainage, compression, and exercise with the goal of volume reduction and patient training. Studies from 2004 through 2011 showed moderately strong evidence in the effectiveness in reducing lymphedema. A 2013 randomized controlled trial compared compression alone to complete decongestive therapy, and mean arm volume reductions were similar in both groups, which was surprising as the compression alone is not intended to increase lymphatic function. Maintenance includes self-care, compression garments, exercise, skincare, and pneumatic compression. Maintenance compression is not expected to reduce volume. However, as we discussed, some studies did show some improvement in volume reduction. The goal of maintenance compression, such as sleeves, is to maintain the current level. Garments should be replaced frequently to maintain compression, as garments can get stretched out. Contraindications include, so there are relative contraindication, hypertension, paralysis, diabetes, and bronchial asthma. And the absolute contraindications include acute infection, uncontrolled CHF, and DVTs. Another method of treatment is intermittent pneumatic compression. A 2022 systemic review concluded that it may be an acceptable home-based treatment option in addition to wearing compression garments in select patients. A non-pneumatic active compression device has also been tested that does not require patients to be immobile during use, and a randomized crossover trial had encouraging results, but further results are needed. In this study, the efficacy of intermittent pneumatic compression as a substitute for manual lymphatic drainage and complete decongestive therapy in the treatment of breast cancer-related lymphedema. Pneumatic compression was studied as a substitute for MLD. Both groups were studied at 5 weeks and at 3 months. Range of motion, pain, tightness, and heaviness improved in both groups. Both groups also showed improvement in the 5 measurement levels of arm circumference as well. Photobiomodulation is also called low-level laser therapy. This treatment uses light wavelengths between 650 and 1000 nanometers to reduce inflammation, promote lymphatic mobility and regeneration, and manage fibrosis. Different conclusions regard effectiveness, and larger randomized trials are recommended. However, in this review article from December 2023, comparison groups were a low-level laser therapy treatment group versus non-treatment group. Quality of life was significantly better in the treatment group. Patients were treated 3 times a week with a laser density of 1.5 to 2 joules per centimeter squared, and patients with treatment had better outcomes in terms of swelling immediately after treatment and at 1 and 3 months follow-up. So surgical treatments can either be reconstructive and aim to restore lymphatic drainage or reductive to decrease volume. In reconstructive LVA, or lymphaticovenular anastomosis, lymphatic channels are identified and supramicrosurgery is performed to create an anastomosis. This can lead to arm volume reduction and fewer episodes of cellulitis. In vascular lymph node transfer, an autologous flap is harvested from a donor site and transplanted to the receptor site usually at the axilla, elbow, or wrist. Donor sites include jejunal, mesenteric, groin, lateral thoracic, omental, or submental regions. 93% of patients reported a high level of satisfaction after a vascular lymph node transfer. However, there is risk of iatrogenic lymphedema at the donor site. Complication rates are estimated to be 14.3% risk of lower limb lymphedema, 21.4% risk of lymphocele, and a 14.3% risk of donor site pain. These surgeries may allow patients to reduce or eliminate compression garment use, but may take months or years to achieve full benefit. For advanced stages of lymphedema with fibrosis present and high adipose content, liposuction-based procedures such as suction-assisted protein lipectomy can be done. This is used to reduce volume in the affected limb. It does not improve lymphatic function, but can reduce limb size to improve patient self-care. It is used in patients with chronic non-pitting lymphedema and has been associated with lower infection rates and improved quality of life. However, it requires a skilled surgeon. In conclusion, breast cancer-related lymphedema involves lifelong management, which makes adherence difficult. Early screening and education is important to reduce progression. Preventative surgeries such as ARM and LYMPHA are effective but not always feasible due to availability. Complete decongestive therapy remains standard of care, however, is not curative. Reconstructive surgeries may be helpful but require specialized microsurgical techniques. As techniques evolve, they may become more feasible for more patients. Reductive surgeries may help in some patients, but is also not curative and requires constant compression use afterwards. No medications have been shown to be safe and effective for breast cancer-related lymphedema. Thank you for your time and attention today.
Thank you, Dr. Albert. Let me now bring in Dr. Soijo, who is a board-certified clinical specialist in oncologic physical therapy, certified lymphedema therapist, and wound care certified. Dr. Joe also is the lead physical therapist for Northwell's Cancer Rehabilitation Program. Dr. Joe.
Good morning. My name is Soijo. I'm a board-certified specialist in oncologic physical therapy from STARS Rehabilitation. Today, I'm going to review several researches about prehabilitation and rehabilitation for surgically treated lung cancer patients. Nothing to disclosure. First of all, let's go over some general information about lung cancer. Lung cancer mainly occurs in older people. About 2 out of 3 people diagnosed with lung cancer are 65 or older. The American Cancer Society estimates for the lung cancer in the United States for 2024 are about 234,580 new cases of lung cancer. The number of new lung cancer diagnoses has been declining steadily since 2006. Mortality rates are also declining, likely due to advances in treatment and early detection. Let's review types of lung cancer. There are 2 major types are small cell lung cancer and non-small cell lung cancer. Small cell lung cancer represents about 15% of lung cancers. It grows and spreads rapidly. Further classified into limited stage small cell lung cancer confined to the one side of the chest. Intensive stage small cell lung cancer has spread beyond the chest. Non-small cell lung cancer are very common, accounts about 85% of lung cancers. Further classified into adenocarcinoma arising from the glandular cells, squamous cell carcinoma arising from flat lining cells, large cell carcinoma undifferentiated cells. The 3 main cancer treatments for lung cancers are surgery, radiation therapy, and chemotherapy. It depends on the stage of lung cancer. There are different options for the surgeries. Thoracotomy is a traditional open surgery that involves making a large incision between the ribs to access the lung. The surgeon may sprout to the ribs to see the lung and nearby organs. Video assist thoracoscopic surgery, which is the VATS, is a minimally invasive procedure that involves making one or more small incisions in the chest and inserting a thin tube with a video camera to see inside the chest. The surgeon then uses small instruments to remove the cancer. VATS is often used for early-stage lung cancer. Robotic assist thoracic surgery is a minimally invasive procedure that uses a robotic system to operate through the small incisions in the chest. The surgeon sits at the console and controls the robotic arms that hold the instruments and camera. Sleeve resection is a procedure to remove a lobe of the lung and part of the bronchi to eliminate a cancerous tumor. The goal is to avoid removing entire of lung. Segment resection is a procedure to remove larger pieces of the rope surrounding that affected area. Last one is a wedge resection, which is a procedure to remove smaller pieces of the rope. Let's move on to the radiation and chemotherapy. Radiation therapy is a common treatment of the lung cancer that uses high-energy beams to destroy the cancer cells. It can be used as a primary treatment, in combination with other therapies, or as a palliative measure to relieve the symptoms. Radiation therapy is used for the lung cancer in the following situations. As a primary treatment for early-stage non-small cell lung cancer that cannot be surgically removed, in combination with the surgery or chemotherapy to reduce the risk of reoccurrence. Lastly, to treat advanced stage lung cancer to relieve the symptoms such as pain, shortness of breath, and bleeding. Chemotherapy is a common treatment for the lung cancer, used to shrink the tumor or stop its spread. The specific drugs and regimen used depend on the type and stage of lung cancer. Chemotherapy is typically administered in cycles with a period of time followed by a rest period. Common combination of drugs including carboplatin, etoposide for small cell lung cancer, carboplatin, teclitaxel, and docetaxel and carboplatin for small cell lung cancer. Other types of treatment that are used to treat certain cancers are hormonal therapy, biological therapy, or stem cell transplant. So these are common side effects with the lung cancer treatment. I'm not going to go over everything. So for surgery, usually it's a pain, cough, fatigue. Chemotherapy, same thing, fatigue, infections, vomitings, neuropathy also can be very common side effects. Radiation therapy, fatigue, cough, radiation fibrosis, weakness, decreased pulmonary functions. So what's the benefit of physical therapy after the lung cancer treatment? It can improve ability of daily activities, fewer complications from the lung cancer surgeries as opposed to doing in a pre-rehab, improve the pulmonary functions, improve quality of life, fewer episodes of shortness of breath as we're working on the pulmonary functions, and improve their strength and then a range of motions. Let's move on to the review some researches that support the benefits of prehabilitation and post-rehabilitation for surgically treated lung cancer patients. The first study was to gather primary information and assess the effects of prehabilitation on those suffering from the lung cancer and having a lobectomy. They reviewed the 15 articles, and all prehabilitation programs focused on increased lung functional capacity, enhanced ADL and patient independence in ADLs, and shorter hospital stay. The outcome measure they used was 6-minute walk test, VO2 peak, VO2 max, and quality of life. Interventions were include breathing exercise, aerobic strengthening, stretching exercise, and walking. The frequency was 8 to 12 weeks program, 1 to 2 times per week for 60 to 120 minutes per session. They conclude that it improves pre-operative and post-operative health through various exercise. They found that rehabilitation program needs to be approached multidisciplinary to increase the physical activity, learning about disease and treatment options, and coping mechanisms to improve quality of life. The second study assessed the benefits of prehabilitation and post-rehabilitation for surgically treated lung cancer patients. The second study, they reviewed the 7 articles between pre-rehabilitation and post-rehabilitation. Average pre-rehabilitation program was an hour-and-a-half session daily, 5 sessions per week for 4 weeks. Program including breathing exercise, intensive spinal exercise, and bike exercise. Post-rehabilitation including aerobic exercise, balance exercise, resistance training, stretching exercise for 4 to 14 weeks of program. They found that pre-rehabilitation improved exercise capacity and reduced post-operative mobility and mortality rate, and post-rehabilitation improved physical performance and quality of life. The last study was focused on post-rehabilitation. They reviewed the summaries, the burden associated with the lung cancer, the management of lung cancer with a particular focus on physiotherapy intervention after the surgery, and further direction for research and clinical practice. A summary of the physical therapy interventions that are used in the management of lung cancer, along with the level of evidence that underpins their use, is provided in this table. Physical therapy interventions vary depending on the stage in disease trajectory and timing relative to the treatment. Physical therapy services for lung cancer have usually been hospital-based and focus on post-operative pulmonary complications after the surgery. However, this table shows that physical therapy management in lung cancer should be prescriptions and delivery of exercise intervention. Physical activity and exercise are vital components targeting 3 main aspects of cancer continuum, which are prevention, mortality, and mobility. So this study also shows the example clinical pathway for the patients after thoracotomy happening in a more acute care. So day 1, post-operative, they start to sit out of the bed and sitting on the chair, and then they're able to ambulate more than 20 meters. And if they keep the portable supplemental oxygens, if their saturation is below 95%, and they can have portable suction if a large air leak presents, and they need assistance from the one person if required, and get aid if they need more than one person to ambulate. They also teach supported cough with a towel wrap, and they also requires respiratory therapy if it's indicated. Day 2, they start to ambulate more than 50 meters, and they still able to keep the portable oxygens if saturation is below 95%, and they get aid or assistance if they are unable to ambulate with one person. And they encourage a supportive cough and continue the respiratory therapy as indicated. Day 3, they review by physical therapist only if patient requires ongoing mobility assistance or respiratory problems. Once the intercostal catheter are removed, they teach upper limb and thoracic mobility, range of motion exercise, and physical therapy, complete the discharge mobility assessment, and provide any discharge planning required for safety. So this gives an overview of what kind of therapy they're getting in patients, and then this would help us to understand what their pathway in patients and transition into the outpatient therapy. This table gives a very good information about general contraindication and precautions to exercise training for surgically treated lung cancer patients. All patients should avoid exercise if hemoglobin level is less than 80, neutrophil count is less than 0.5, platelet count is less than 50, fever is higher than 38 Celsius degrees, and if they complain about extreme fatigue or severe nausea. For aerobic exercise, if a patient complains upper or lower limb lymphedema or swelling, they should wear compression garment during the exercise. Patients have a peripheral limitation such as a severe cancer cachexia or muscle atrophy, commence with the resistance training and then progress to incorporate aerobic training once muscle bulk and strength is improved. For resistance exercise, patient has a high risk of bony metastasis, prescribe with cautions, recommend medical clearance. If patient have a high risk of osteoporosis or bone fracture, prescribe with cautions. Patient has a cardiorespiratory limitation such as chemotherapy-induced left ventricular dysfunctions or severe anemia, exercise are generally contraindicated. Post-operative patients care with the wound healing. Often requires 6 to 8 weeks post-operatively for healing prior to start with the resistance exercise. For stretching exercise, post-operative patients should avoid upper limb stretches until removal of intercostal catheter. Finally, they summarized the future directions for research and practice. They found the current study has a limitation with a small and lack of randomizations and control groups in exercise studies. Also, they found the limitation for the long-term follow-up. A lot of patients fall out during the middle of the study. So they hope to see the next future direction for research will be looking into the efficacy of exercise to improve survival rate in lung cancer. And exercise lung cancer is a growing area, so they want to look into the more clinical research. This brings us to the end, and Dr. Davis will present next. Thank you. Here are my references.
Thank you, Dr. Joe. Now let me introduce our next speaker to you all, Dr. Chanel Davidoff. Dr. Davidoff is a physiatrist with Northwell, as well as fellowship trained in cancer rehabilitation medicine. Dr. Davidoff also is an assistant professor with Zucker School of Medicine. Dr. Davidoff will cover cancer-related fatigue with us today. Dr. Davidoff.
Hello, everyone, and thank you for joining. My name is Chanel Davidoff. I'm a cancer rehab physiatrist working primarily out of Manhattan at Meath and Lenox Hill Hospital. I am going to be speaking on evolving strategies in understanding and alleviating cancer-related fatigue. Okay, so some of the objectives for our talk today. So we're going to, of course, define what cancer-related fatigue is and try and understand its impact on patient quality of life. And we're also going to explore different screening and assessment tools for cancer-related fatigue in different clinical settings to be able to enhance early identification and therefore have comprehensive management. And most importantly, we're going to review the current updated guidelines for cancer-related fatigue management and highlight any updated based recommendations for both pharmacologic and non-pharmacologic intervention based off current evidence. So as we all know, cancer-related fatigue is one of the most common and distressing side effects of a cancer diagnosis and treatment. And in fact, 30 to 60% of patients experience moderate to severe fatigue during their treatment. And 20 to 30% experience fatigue for months and years after even treatment completion. So this can really affect patients at any time during their cancer trajectory and into long-term survivorship. And it's a very relevant symptom, throughout the spectrum of care. So what is cancer-related fatigue and how is it defined? So multiple sources, including the NCCN guidelines and ASCO, really define this as persistent and distressing feelings of physical, mental, and emotional fatigue. So this differs then in this exertional fatigue in that symptoms are really not relieved by any rest or having a sufficient amount of sleep. And it's not really proportional with the amount of physical activity someone is doing in their day-to-day. And it's really rarely an isolated symptoms. This commonly coexists in what we call these symptom clusters that some cancer patients may experience. And it truly impacts every aspect of quality of life, whether it's physical, emotional, and occupational functioning. So how does cancer fatigue occur? What is the etiology and pathophysiology of this? So really the etiology is very complex and it's often what we call multifaceted. So it can come from cancer and its treatment effects, it can come from physical symptoms such as pain, insomnia, and dyspnea, inactivity and deconditioning, psychological comorbidities, metabolic derangements, and even nutritional deficiencies. And as a result, mechanism of fatigue is really just poorly understood because it's so multifaceted. So some sources say there's just a lot of biopsychosocial factors that may be involved as well, and some other proposed theories include some immune and inflammatory mediators that have effect on the central and peripheral mechanisms of the body. So because cancer-related fatigue has been, so complex, right? There have been new proposed ideas such as the 3P factors biopsychosocial model to help us understand the complex disease processes involved. And this includes understanding predisposing factors to fatigue, precipitating factors, and perpetuating factors. And starting off with predisposing factors, which it basically is someone's risk of developing cancer-related fatigue. And this can include age, sex, genetics, body composition, nutritional quality, and medical comorbidities, and any psychosocial issues that someone may have pre-existing, such as their perceived stress or depressed mood or anxiety or, difficulty with adjustment. Some precipitating factors, this includes things that may trigger the onset of fatigue. So things like systemic therapy and radiation, metabolic dysregulation, and inflammatory response as a result of treatments or cancer, and of course, occupational disability. Perpetuating factors are actually things that worsen or prolong the duration of cancer-related fatigue. And this is what we might see kind of in the long run into survivorship if patients still struggle with fatigue. And this includes things like ongoing physical inactivity, deconditioning, cachexia, anorexia, inability to eat, sleep disturbances, and social isolation. So I wanted to take this opportunity to highlight a really important and seminal article on cancer-related fatigue done by Bauer and her colleagues. This was recently published in the Journal of Clinical Oncology, and it basically highlights updated recommendations on how to manage fatigue in cancer patients, and highlights some small adjustments based on previous recommendations. And I really source this throughout the entire presentation. So very good article. And of course, most of the talk is also referencing the current NCCN guidelines on cancer-related fatigue. So just to touch upon screening for cancer-related fatigue. So the current guidelines recommend to screen for the presence of fatigue from the point of diagnosis, during treatment, and immediately following treatment, and actually annually into survivorship at least. And this is important to note any patients with any predisposing factors prior to treatment that may deem them susceptible to getting, worsening cancer-related fatigue, and start the education process early on. Also important to document quantitative or semi-quantitative assessments, and some may use actual fatigue measurement scales, and I have a few listed here in the chart on the right. Some include the FACT-F and the Brief Fatigue Inventory Scale are the most common, all of these ranging just depending on how comprehensive you want to be with data collection. But if fatigue measurement scales are not accessible or they're too comprehensive, just having some kind of numeric scale to quantify fatigue is recommended. So just as easy as a scale of 1 to 10. If patients score between 1 and 3, that's usually considered mild. Anything between 4 and 6 is moderate, and anything above 7 is severe, considered severe fatigue. And this is important because once you get in the severe fatigue category, we start to notice a decrease in physical function, and this may trigger a more comprehensive assessment by the oncologist or may trigger referrals to physical therapy or physiatry. And recommendations basically state that those scoring moderate to severe fatigue require a more comprehensive assessment. So screening with the question, scale of 1 to 10, where's your fatigue at today? Anything above 4 requires a more in-depth kind of questioning and assessment. So what goes into the assessment of fatigue in a cancer patient? So they scored a moderate to severe, and so this prompted you to ask more questions, right? So taking a focused fatigue history, asking things like the onset, the pattern, duration of fatigue, has it changed over time, aggravated or alleviating factors, does it improve with sleep, does it not change with sleep, how much activity are they doing in day-to-day? Also important to review disease and treatment status, seeing if their disease has been stable, any recent staging scans that have been done, and of course, understanding what treatment they're currently receiving, which can contribute to, may or may not contribute to their fatigue. And of course, current medication reviews. As we know, some medications, whether or not it's to help manage pain, can also be sedating. So review of current medication lists is recommended, and also review of concurrent symptoms. So some concurrent symptom clusters that may co-occur with fatigue include things like pain, insomnia, poor appetite, decreased endurance, medication side effects, as we discussed, things like anemia, especially if they're undergoing current chemotherapy treatments, and of course psychological distress. And important to try and assess all these things and see if we can treat any of these contributing factors. So if we're noticing that a patient's having issues with one of these domains, maybe that's an area we can start to intervene. And of course, asking about a patient's functional status, any effect on their ADLs and mobility and activity level, how severe has this gotten in their and how has it impacted their day-to-day life? And what's their social support like? Who's home with them? Who's helping them? Do they have people that they can talk to if they're in distress? The next part of the assessment may be ordering lab work or diagnostics. And this may start with reviewing surveillance imaging that a patient may have had, whether it's a CT chest, abdomen, pelvis, or a PET scan, just to get an idea of where they are in their disease trajectory. CBC with DIF is very helpful to be able to compare end of treatment H&H, assess for anemia, new leukopenia, or neutropenia. A CMP to look at electrolytes and assess for hepatic or renal dysfunction. Endocrine panels to see if there's any hypothyroid issues going on. And of course, vitamin and micronutrient levels, specifically things like vitamin D, B12, folate, or magnesium. I really liked this chart from Bauer's article, as mentioned earlier in the presentation, and it's a summary on comorbid conditions and other treatable contributing factors that could be associated with fatigue and examples of possible diagnostic evaluation. So things like cardiac dysfunction, endocrine, pulmonary, renal, anemia, arthritis, neuromuscular issues, sleep issues, pain, and emotional distress. So I really like this because it's kind of like a comprehensive checklist on things that I want to make sure I'm not missing when I'm assessing someone, especially with severe fatigue, and where to start in terms of the diagnostic approach. So after we completed a comprehensive assessment and addressed any underlying or contributing causes of fatigue, we can now think about management. And it's important we first approach management with seeing where they are in their disease trajectory. And this is because the current guidelines and recommendations are actually different depending on where they are in their treatment stage. So whether they're undergoing active treatment, post-treatment, or end of life, those three scenarios will have different recommendations. And just to give an overview of what the treatment care map may look like. So we've already talked about treating contributing factors and symptoms. And no matter where a patient is on their disease trajectory, or whether they're undergoing active treatment or not, the initial approach to management is always patient and caregiver education, which we'll get into. And then we think about non-pharmacologic interventions, pharmacologic interventions, and then we try and reassess to see if any of our interventions are being effective, or see if there's any new symptoms that we need to address. So current guidelines state that all patients, no matter where they are in their disease trajectory, should receive education, and including their caregivers as well. And what does this look like? So during active treatment, this may look like just giving someone general education about cancer-related fatigue and giving them information about the differences between normal fatigue versus fatigue related to cancer, and providing a lot of reassurance that it's, not all in their head, this happens, this is a multifactorial process, encouraging them to self-monitor fatigue levels using a fatigue diary, help identifying any patterns of fatigue, and encourage some kind of structural physical activity. It doesn't have to be, an exercise program, but something to get their body moving, as much as they can and that can tolerate. And of course, discussing energy conservation techniques. And some energy conservation strategies may include first talking about setting realistic expectations and priorities. What kind of activities do they prioritize? Talking about the pace of an activity, things that they can actually delegate to someone else to help conserve their energy for other things. Scheduling activities at peak energy. Talking about labor-saving assistive devices. So, for example, asking a patient if they would be willing to use a rolling walker because it's just going to help conserve their energy more than trying to walk, independently. Encouraging to limit daytime naps close to bedtime so it doesn't interfere with their sleep at night. Encourage just structured daily routines, trying to do things in somewhat of a structured way day to day to give some kind of cyclical pattern, and try and attend to one activity at a time and not feel so overwhelmed. Someone is immediately following treatment, their education, about cancer-related fatigue may be similar to those given to that undergoing active treatment. Those who are kind of at the end of life stage, the only difference would be to talk about eliminating any non-essential activities, and maybe the focus is less so on physical activity, but more how do we conserve energy for activities they value most, whether it's having the energy to be up and talking with family rather than going to physical therapy or doing any kind of exercise program. So it's very individualized. So what is the current evidence for management of cancer-related fatigue? So these charts were derived directly from the most up-to-date ASCO guidelines article. What they do is basically summarize the interventions and recommendations based off of symptom setting. And for those undergoing active treatment, the interventions with the highest quality evidence and the strongest recommendations are exercise, which is no surprise there, cognitive behavioral therapy, and mindfulness-based programs, and Tai Chi. And secondarily, there was some moderate evidence for psychoeducation, but only a conditional recommendation, and also some evidence, but low quality, for use of American ginseng supplement, which was also a conditional recommendation. And the current evidence for management of fatigue for those after they completed treatment is still number one being exercise as the general recommendation, cognitive behavioral therapy similar to those undergoing treatment, and mindfulness-based programs as well. And then low quality evidence was shown for things like yoga, acupuncture, and something called moxibustion, which is rooted in a traditional Chinese medicine technique in acupuncture. It's basically burning a dry herb near specific points in the body. So the reason why the evidence is the recommendations for the yoga, acupuncture, and these techniques after treatment is because that's what was studied. They weren't studied during treatments, so the evidence for it is only observed after treatment has been completed, which is why the recommendations remain such. And these are conditional recommendations, but those with strong recommendations are still exercise, CBT, and mindfulness-based programs. So management at end of life is a little bit different. The evidence for exercise and physical-based activities are not as robust and not well studied, but there is some low-quality evidence to suggest that cognitive behavioral therapy and use of corticosteroids can be helpful, and these are really conditional recommendations and individualized based off of, you know, patient needs and values and goals of care. So one important update is that the guidelines now advise against prescribing wakefulness agents and psychostimulants to alleviate cancer-related fatigue as first line. So that's during active treatment, post-treatment, as well as end of life. And as during active treatment as well, they are also advising against use of L-carnitine, which had some evidence for cancer-related fatigue, and use of antidepressants as the initial first line, and rather recommending cognitive behavioral therapy or mindfulness-based activities as the initial approach during this time. And I think this is because the current literature does not usually support this routine use for this medication, because the long-term effects and safety profiles in these agents in the context of cancer really remain unclear. So there's a lack of evidence also in addressing, in these agents, in addressing the factors that can contribute to cancer-related fatigue. I will mention one caveat and one exception, maybe those with brain tumors. And in this setting, I think that a lot of the times use of these neurostimulants to help with neurocognitive function may be appropriate in that particular settings. This for lethargy and stuff like that related to more brain injury mechanisms. But I think in this case, when we're talking about, you know, cancer-related fatigue as it pertains to just treatments or you know, cancer or other symptom clusters, that's not typically recommended to use these agents. I wanted to also talk about specific interventions that had the most evidence, and number one being exercise. And so a majority of the trials really focused on exercise, which is why there was the most amount of supportive evidence for this. And it showed a lot of benefits for on exercise on alleviating symptoms of fatigue, but really wasn't very, the evidence was pretty insufficient for the end of life stage. And although the guidelines don't specify optimal dose, intensity, and duration, the American College of Sports Medicine has put forth physical activity guidelines for cancer survivors. And it should, and they do recommend a combination of aerobic and resistance training for management of fatigue symptoms. And these are their specific guidelines and recommendations on their site. It's helpful in that it improves not only physical well-being, but emotional well-being as well, and many other symptoms that may contribute to fatigue. And as mentioned, it's beneficial for those on active treatment and post-treatment, and even into survivorship. And just remember and encourage patients that movement is medicine. So talking about cognitive behavioral therapy, or CBT. So research in this space has grew significantly, demonstrating really good benefits for cancer-related fatigue symptoms. CBT is oftentimes conducted by a psychotherapist, or maybe even a psychiatrist, or a specialized therapist, behavioral therapist. And we actually have that accessible at where I'm at with the Cancer Institute, which has been great and beneficial for patients. And it's been shown to be both effective during treatment phases and post-treatment phases, as well as end of life. Helps with coping strategies and adaptive thinking about fatigue symptoms, and at end of life, maybe talking about, you know, dignity and the meaning of life and such, helping to kind of promote mindfulness and positive behaviors. And also helpful to reduce overall symptom burden, which we know can coexist with fatigue. So this is something to consider prioritizing as an initial strategy for fatigue management. So there are a lot of evidence on use of different type of integrative therapies for managing fatigue in cancer patients. One of the most studied interventions is actually use of acupuncture, as well as participating in Tai Chi. So those are the integrative therapies with the most amount of evidence, so therefore were most likely to be recommended. Secondary to that was the acupuncture type of technique called moxibustion, which you can see in the picture here, is again using kind of aromatherapy, which had some evidence, so only conditionally recommended, as well as use of American ginseng, which had some evidence to support that it's helpful with fatigue symptoms. However, conditionally recommended because unclear if certain supplements may have potential interactions or contraindications with systemic treatments. And the only change now is that L-carnitine is now no longer recommended based off of lack of good evidence to support its use and potential contraindications and interactions with its use. But other things in the gray, coenzyme Q, music therapy, reflexology, massage, omega-3, bright light therapy, brainwave vibration, meditation, those kinds of things, may or may not be recommended, may not be directly harmful, but insufficient amount of evidence to suggest that it's directly helpful. So what do the current guidelines have to say about the pharmacologic interventions at our disposal? So as mentioned before, the wakefulness agents and psychostimulants such as methylphenidate and modafinil are now no longer routinely recommended during or post-treatment or end of life. Again, there may be caveats or conditional recommendations for those with brain tumors, and that should be in a discussion with the cancer care team. Antidepressants, the one that's most studied in this setting is paroxetine, but now it's no longer recommended during active treatment, instead recommending to start off with cognitive behavioral therapies and mindfulness-based activities. Steroids, such as dexamethasone, has some good evidence to suggest that may be helpful at the end-of-life stage. And finally, just to summarize the key points, so guidelines of cancer-related fatigue management should be comprehensive and recognizing the condition is actually multifactorial and often co-occurring with other symptoms. So recommendations may vary by disease and treatment status and predominant symptoms. For screening, all patients should be screened for cancer-related fatigue, and those with moderate to severe fatigue require further workup to identify reversible or contributing causes. The top interventions, exercise has the most robust evidence for reducing cancer-related fatigue and is highly recommended. Secondary is cognitive behavioral therapy is also effective, especially for addressing the emotional and cognitive aspects of fatigue. In terms of pharmacology, routine use of psychostimulants and wakefulness agents are not recommended. The focus really remains on non-pharmacologic treatments at this time. And personalized care. Management should really be tailored to each patient's needs and considering their specific disease and treatment phase and overall health. And here are my list of references. And thank you everyone for joining and the opportunity to present on this topic.
All right. So it is 10:02 now, and we still have a packed agenda for the next set of presentations. So what I would suggest is let's take a stretch break, perhaps 8 minutes, and let's resume at 10:10. So we'll restart back on at 10:10, okay? Thank you. Welcome back, everyone. Let's resume with Dr. Jonas Sokolov, who is the Director of Functional Medicine and Oncologic Rehabilitation at Catholic Health Systems. Dr. Sokolov will discuss with us various strategies to manage radiation-induced fibrosis. Take it away, Dr. Sokolov.
Good morning. Pleasure to be with you all today to discuss radiation-induced fibrosis and provide an overview of treatment strategies based on an integrative oncological rehabilitation approach. I'd like to give you guys a sense of how we approach patients with radiation fibrosis from a rehab standpoint or rehab medicine standpoint. We'll provide various strategies that we try to implement in clinical practice. We'll discuss some pharmacologic management of the condition, as well as we'll talk about what potential root causes of the condition are hypothesized to be, and perhaps where we might be able to address some of these root causes. And then we'll discuss an emerging treatment for this condition. So in order for us to understand the treatment of radiation-induced fibrosis, we have to have a basic understanding of tissue healing. So in normal healing, there are essentially three main phases. You have the inflammation phase, the proliferative phase, and the maturation or remodeling phase of healing. In inflammation, the purpose is to remove dead or damaged tissue and to prevent infection. So the key features of this phase would be the release of pro-inflammatory cytokines such as tissue necrosis factor alpha, interleukin-1 and interleukin-6, the recruitment of various cells involved in inflammation, neutrophils and macrophages, for example. And then we have, through activation of growth factors, activation of fibroblasts and other cells such as endothelial cells and mesenchymal stem cells. Usually the inflammatory phase lasts several hours to days, and then we move on to the proliferative phase, which usually takes place within days to weeks later. And the purpose of the proliferative phase is to restore tissue structure. And in this phase, the key features are fibroblasts produce extracellular matrix components and lay down immature type collagen. You get angiogenesis occurs, so the formation of new blood vessels, and then you get a reepithelialization to restore integrity of the tissue. But you don't have well-structured collagen matrix or collagen material. It's very disorganized and sort of immature type collagen. After proliferation is finished, usually after within several weeks to even months, we move on to a maturation phase of healing, and the purpose of this phase is to strengthen and reorganize the repaired tissue. So we have immature collagen that then is sort of transformed into more organized, more well cross-linked and remodeled collagen, more mature type collagen material. Excess extracellular matrix is degraded by metalloproteinases, and myofibroblasts contract the wound and they then undergo apoptosis. Well, what happens in radiation fibrosis is this whole system just goes awry, where you get a dysregulated response of the inflammatory phase of healing. DNA damage, usually that is the result from DNA damage, oxidative stress from the radiation itself. So you get an overproduction of these inflammatory cytokines, as we described. You get an activation of macrophages and fibroblasts that is sort of prolonged. It's a prolonged, more robust response. So instead of resolving, it actually, the inflammation is propagated and continues on and becomes chronic, and this leads to ongoing tissue damage. You also get disruption of the proliferative phase in radiation-induced fibrosis, where you get an aberrant extracellular matrix production. Fibroblasts transition into hyperactive myofibroblasts, and then they undergo the influence of TGF-beta. Overproduction of disorganized collagen, and then the laying down of, again, disorganized collagen, immature collagen, just a collagen matrix that's all in disarray and not well formed. And that's what creates this fibrotic material. Maturation phase is also disrupted in radiation fibrosis, where again you get excess collagen deposition that's improperly cross-linked. The cross-linked matrix of these collagen material is again not well formed, and that creates this very rigid, non-compliant type of tissue. You get a persistent hypoxia that just drives the whole process. So sort of in a nutshell, that's essentially what happens in radiation fibrosis. So what happens in radiation-induced fibrosis is that usually the condition starts to occur within the first 12 months, or after the maturation phase has already started probably, and it can progress over several years. It manifests usually as skin duration initially, then that progresses to thickening, then muscle shortening, and then atrophy. This is followed by or accompanied by limited mobility. Sometimes we see edema or lymphedema initially, fibrosis, ulceration, and fistula formation. Clinical manifestations can include neck stiffness, inability to open the mouth, and trismus, xerostomia, such in the head and neck population, for example, decreased vocal quality, osteoradionecrosis, dysphagia, inability, difficulty swallowing, and then of course all the neural structures can be affected. We can have pain, and we can have various disruption to the entire neural axis, extending from the spinal cord to the plexi, to the nerve roots, and even into the peripheral nerves. You'll see in this presentation that I have used head and neck cancer as an example to illustrate some of these concepts regarding radiation-induced fibrosis. I feel that radiation fibrosis is particularly problematic in the head and neck cancer population, and also provides a very good illustration of the pathology. So here we have oral mucositis, as you see on the left, as an initial sort of presenting problem in the radiation fibrosis syndrome. Then that can also manifest, an early manifestation can also be dermatitis, induration of the skin. And the process can then go on to extend the deeper soft tissue structures, the muscles, tendons, ligaments, when then you can start to develop shortening of these structures and then atrophy. It can also affect bone, and as I mentioned before, nerve damage also can occur, and this can be in the form of demyelination or even an axonal loss. Prognosis for the condition is it tends to be a permanent condition, meaning that we don't have a cure for this. It never really seems to go away, and it oftentimes tends to be progressive or lasting lifelong. Risk factors would include radiation dose. Obviously, the higher dosage utilized, the greater chances of developing fibrosis, the field of radiation, and of course the technique, whether you have a concentrated beam or dosage of radiation versus a more diffuse or dispersed beam can affect can cause a greater risk of developing fibrosis. Age plays a role, advanced age being a higher risk. Genetics, some people just the way they heal due to various selective nucleotide polymorphisms, for example, may have a propensity to lay down more sort of immature collagen, so they may be more susceptible to fibrosis than other people just by a genetic difference. And the various comorbidities, obviously, metabolic disturbances, type 2 diabetes, and other comorbidities tend to place people at risk as well. As I also mentioned, symptoms are typically pain, stiffness, restricted range of motion, functional impairment. Can occur really anywhere in the body, anywhere that has been treated with radiation, this can arise. Again, utilizing head and neck as a good example of the pathophysiology clinical presentation of radiation fibrosis. We see here on the slide lymphedema, often seen as an initial manifestation of fibrosis. This is followed by the actual shortening or hardening from the deposition of abnormal collagen material, leading to the actual fibrotic component of the condition, where there's a lot of tightness and restricted range of motion. The anatomy is very hardened to palpation and often tender. And then this progresses on to usually involving some sort of atrophic component. Syndrome. Diagnosis is usually clinical, but there are some imaging modalities that can be helpful when trying to decipher an origin or trying to identify the process early on, which is usually key in treatment. MRI imaging, as you see up top, this is an MRI, the chest. You can see the breast tissue there, the fibrotic material, where the arrow is pointing to after this patient was treated for breast cancer using radiation. And then the subsequent below slide picture is an ultrasound image. An ultrasound elastography is rapidly becoming a useful radiological modality in identifying fibrosis early on. Radiation fibrosis significantly impacts quality of life. We know from extensive epidemiological data that radiation fibrosis has just really alters quality of life. There's a greater increased morbidity, higher pain interference scores, lower mobility, ADLs, and of course psychosocial well-being. The way that we approach this in our practice and using a sports medicine rehabilitation model, again, this is not my, I didn't come up with this. This was passed on to me by two physicians at the Mayo Clinic. But I like to use this model in my approach, really in all of onco rehab, and with the goal of being successful return to play or successful return to life, if you will, rounding the bases to get to home base. Must have a team approach, and we must start by first step has to be pain control. A lot of these folks will present with some sort of pain complaint, and we have to have a means to control this pain, whether that's pharmacologically, whether it's from procedures, injections, or from various integrative techniques such as manipulation, or supplementation. We have to have the first step as pain control. Then we progress on to range of motion, restoring range of motion, moving on to strength training, and then endurance training. And of course, we must also consider the regions below and above the area affected, so we must look at the kinetic chain as well. So that is sort of how we structure the overall prescription in a rehabilitation protocol. Of course, we want to be aggressive in treating lymphedema, as lymphedema is often the first initial presentation of radiation fibrosis. So we want to be vigilant in getting rid of lymphedema, because the longer that fluid sort of pools or stagnates, the greater chances of developing that fibrotic tissue that we talked about earlier. Of course, complete decongestive therapy being the mainstay of treatment, we have various other tools at our disposal, such as pneumatic compression devices, the LymphaTouch device that you see there on the bottom right corner, and other modalities. Compression garments often are useful, so again, we want to be able to identify this condition early on and treat it aggressively. I'll give a plug for osteopathic manipulative treatment. As an osteopath, I do find this treatment to be helpful as a way to control pain and to help restore range of motion. At least in my practice, I do find many patients, after going through cancer treatment, tend to be less inclined to start medication. They sort of don't want to be poked and prodded. They don't want to have injections. They prefer a so-called more natural approach to treatment, and OMT has been a useful tool. I'll talk about trismus because this is sort of a unique condition that we see in our head and neck cancer radiation patients, where you get fibrosis of the muscles of mastication. You can get direct damage or direct scar tissue, fibrotic scar tissue in these structures, but you can also get ectopic firing from trigeminal nerve damage from radiation or trigeminal fibrosis that can create spasming of the muscles and an inability to open the mouth. You can also get direct contracture of ligaments around the TMJ that can also contribute to this. We have a couple of different mouth opening devices on the market, the Dynaspin device that you see on top and the Therabite device on the bottom to help with passive stretching of the mouth. Limitations would be many of these devices are not covered by insurance and can also just be cumbersome sometimes for patients to use. I have found them to be helpful in my practice. Really, the treatment for trismus is having a great team, mainly a great team of therapists that are skilled, have experience working with folks with this condition, have experience with intraoral therapies and intraoral manipulation, and then convey that information, knowledge, and techniques to the patient themselves. And then if all else fails, we do have injection therapy. So we do use botulinum toxin injections to treat this condition, especially when there is an ectopic component, ectopic firing component to the trismus, where the muscles are firing dystonically. We can use Botox to treat this. Certainly in cervical dystonia, which we do see in radiation fibrosis after radiation to the neck region. Again, we can see an ectopic firing of the musculature of the neck that would be responsive to botulinum toxin injections. However, in many instances, the loss of range of motion can be directly related to the fibrotic component or actual scar tissue component from radiation fibrosis, and that would not be amenable to botulinum toxin injection. Of course, it's helpful to have ultrasound or other ways to identify the various muscles in the neck, since many of these muscles can be hard to identify clinically. So it's helpful to have ultrasound, which we have in the office. And if you don't have ultrasound, EMG guidance is also a good second option for Botox injections. There's good data on the efficacy of Botox for the treatment of cervical dystonia. I don't really need to review that here. There are side effects that can be associated, but generally the procedure is considered to be safe. Dysphagia, neck weakness, head drop, increased pain, all can be side effects. Botox at lower doses has been shown to have anti-nociceptive effects, so just keep in mind that if you don't have dystonia or muscular contraction, whether that's really anywhere in the body, but let's say in the head and neck region, let's say you have more issue related to pain from fibrosis, Botox injected subcutaneously, I have found anecdotally, and there is some report, not high quality data, but there is some report in the literature that this can be an effective means to control pain, and generally also very safe. So that's something to keep in mind as well. And the dosages tend to be lower at low doses. Botox has anti-nociceptive effects, and even on the subcutaneous level, have found this to be helpful. Pharmacologic treatment, really the only thing that has been studied that shows any sort of promise is pentoxifillin. It's a medication that's primarily used to improve blood flow by reducing blood viscosity. It enhances microcirculation, increases oxygen delivery to tissues. More importantly, though, pentoxifillin has anti-fibrotic effects. It modulates the activity of fibroblasts, thus reducing collagen deposition, and prevents excessive scar tissue formation. So it has an off-label use for radiation fibrosis. There are some moderately quality data, randomized controlled data supporting its use. Usually this has been done in conjunction with vitamin E, which also has that sort of anti-fibrotic effect as well. However, if we wanted to really get down to the root sort of cause of really what is happening and why we have this disarray in the healing cascade, and why we have this abnormal deposition of immature, unorganized collagen material that causes fibrosis, we really have to look at the subcellular level and look at the mitochondria, right? The powerhouse of the cell. So what we find in all cases is that we have mitochondrial dysfunction. So disruption directly, likely from the radiation itself, causes mitochondrial toxicity and mitochondrial death. This then leads to oxidative stress, and this then leads to inflammation. So a prolonged inflammatory phase of healing really disrupts the whole healing cascade, and you can sort of get the picture of how this sort of abnormal scar tissue can be deposited. Promising in this regard is the emergence of photobiomodulation therapy. So photobiomodulation therapy, formerly known as low-level laser light therapy, is a non-invasive treatment that uses specific wavelengths of light, typically in the red or near infrared spectrum, to stimulate cellular function. Photobiomodulation therapy also has been studied for its potential benefits in reducing inflammation. It accelerates tissue repair, relieves pain, and overall helps to improve cellular metabolism. Why? Because it seems to have a direct effect on the actual mitochondria itself. So the photobiomodulation wavelength of the light that's emitted from these devices is absorbed by the mitochondrial chromophores, particularly cytochrome C oxidase. And then this triggers increased ATP production. And then you get enhanced cellular repair and regeneration, a reduction in oxidative stress, reactive oxygen species, and less inflammation. It also can modulate the immune responses as well. Good data on this, and this is really showing some promise in helping with radiation-induced fibrosis. Also very interesting, there is some data emerging as well to treat lymphedema as well. So it's used really at the point of care in clinic. It can be administered by a physician, a nurse, even a medical assistant. Really the only precaution you have to follow is protective eyewear, as you can see here in the photo. It's being used in major academic centers right now. For example, I know that for University of Pittsburgh is using this in their cancer center to treat oral mucositis and having really good results. However, PBM, photobiomodulation, is not the only thing that can help enhance mitochondrial function or help regeneration of mitochondria. Various lifestyle factors as well. So an anti-inflammatory type diet, right? We know that ultra-processed foods are metabolically dysfunctional. Can help disrupt mitochondrial function. Various toxins in our environment, such as pesticides, heavy metals, microplastics, fluoride, air pollution, smoking, all disrupt mitochondrial health and mitochondrial function. Sleep deprivation, lack of physical activity, lack of exercise also promote poor mitochondrial health. So these factors should be addressed in any rehabilitation prescription in order to optimize metabolism and optimize metabolic health, mitochondrial health. Perhaps we can slow down the process of radiation fibrosis. So in summary, it's really helpful to have skilled, experienced rehabilitation team when you're treating folks with radiation fibrosis. So folks who really have seen the nuances of this condition and really have developed effective tools to treat it. Medical intervention is sometimes necessary. Pentoxifilin with vitamin E does show some promise and is relatively safe to use. Botox injections and other forms of injection therapy can be helpful. And always working with a multidisciplinary model of care to include lifestyle practitioners such as nutritionists, health coaches, in the care model as a way to help optimize mitochondrial health and metabolism. Thank you so much for your time. I hope you enjoy the rest of the conference.
Thank you, Dr. Sokolov. Let's now bring in Dr. Taylor Jensen, who is a pediatric physical therapist with Northwell's STARS Outpatient Therapy Network. Take it away, Dr. Jensen.
Hi, my name is Taylor Jensen, and I will be presenting functional impairment and pediatric cancer survivorship. Our objectives for today are to identify the most common pediatric cancers, discuss treatment options, and recognize the importance of physical therapy and a patient's comprehensive plan of care. Some pediatric cancer facts. Each year, approximately 400,000 children and adolescents under 18 have cancer. The 5-year survival rate for these individuals between the years of 2000 and 2016 was 85.4% and is on the rise due to new treatment options. The most common types of pediatric cancers, which are listed from most common to least, are leukemia, brain and/or central nervous system tumors, lymphomas, and sarcomas. Today, we're going to focus on the 3 most common types. Leukemias. This is the most common form of pediatric cancer that begins in the blood-forming cells found in the bone marrow. It occurs when defective non-functional white blood cells, or leukocytes, are produced largely and displace the healthy leukocytes. And the function of leukocytes is to help defend against infectious agents, including viruses, bacteria, and fungi. There's acute and chronic leukemia. Acute myeloid leukemia, or AML, originates in the myeloid cells, which are the granulocytes and monocytes, which become the white blood cells. This type of cancer typically occurs within the first 2 years of life, and the survival rate is 69%. Acute lymphocytic leukemia, or ALL, originates in lymphocytes, which are the T cells, B cells, and NK cells. And this is most common in 2 to 5-year-old children. And if it's treated quickly, the survival rate is 90%. Brain and central nervous system tumors are the second most common type of pediatric cancer. They're classified by the type of cell or tissue in which they originate or by the location that they are found in the central nervous system. The most common is astrocytomas, which account for 35% of CNS cancers, and they're found primarily in the brain. Medulloblastomas account for 18% of CNS cancers, and they're rare in adults but common in children, especially those under 10 years old. And they most commonly arise in the cerebellum, but they can spread throughout the central nervous system. Ependymomas account for 5% of CNS cancers, and they arise from neuroglial cells that line the ventricular system of the brain and the central canal of the spinal cord. And these range in severity from low to high grade. We also have embryonal tumors, and these tumors arise from embryonic tissues that fail to mature. These can include neuroblastomas, retinoblastomas, or Wilms tumors, which are also called nephroblastomas, and these are common in children less than 4 to 5 years old. Lymphomas are the third most common pediatric cancers. The B cells and T cells can become cancerous, resulting in the production of large numbers of abnormal and non-functioning lymphocytes. Lymphomas can occur in the lymph nodes, spleen, bone marrow, and thymus, as well as the lymphatic structures in the brain, GI tract, and liver. And they basically make it hard for the body to fight off other illnesses. We have two main types, Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma consists of abnormal B cell production. It typically begins in the lymph nodes of the upper body. This is rare in children under 5 and is most common in adolescents. The 5-year survival rate for Hodgkin's lymphoma is 98%. Non-Hodgkin's lymphoma consists of abnormal B cell and T cell production. It occurs frequently in children greater than 5 years old, and the 5-year survival rate for this type is 90%. Sarcomas are solid tumors that are found in either muscle, bone, cartilage, and fat. Osteosarcomas are the most common in the pediatric population, followed by Ewing sarcoma. Osteosarcoma is typically found in the bone, whereas Ewing sarcoma is found in the bone and the surrounding soft tissue. And both of these types of sarcomas are typically seen in children around puberty and/or adolescence. Treatment on functional impairment. Many survivals will experience treatment-related medical, cognitive, and psychological impairments that interfere with normal development. Fatigue is the most common symptom that's reported from the pediatric cancer patient, and medical treatment options can include glucocorticoids, chemotherapy, radiation, surgery to remove the tumor, stem cell or bone marrow transplants, and targeted therapies and immunotherapies. And the deficits impairments can vary dependent on the treatment that is used. Chemotherapy agents have many side effects and may cause peripheral neuropathy, distal symmetric weakness, decreased deep tendon reflexes, weakness in ankle dorsiflexors, foot drop, and cardiovascular issues. Increased steroid use causes higher risk of osteopenia and osteoporosis, and also avascular necrosis. Increased radiation exposure can also lead to avascular necrosis and cerebrovascular issues when the radiation is along the central nervous system. For bone sarcomas, there's options for limb-sparing surgeries or amputation, and this could lead to decreased overall activity, which will impact physical and mental health. For central nervous system tumors, if they're surgically removed, they could affect motor skills, vision, affect, speech, coordination, and balance, etc., dependent on the region where the tumor is. And other general effects can include poor physical fitness, decreased quality of life, and joint contractures. So why is physical therapy important? The optimal time to begin physical therapy is at the time of diagnosis, if possible. Prehabilitation should be implemented for functional baseline and to promote physical, cognitive, and psychological health. It's important to address functional deficits that we find, and general exercise therapy can improve cardiovascular, respiratory, musculoskeletal, and metabolic functions. It can improve quality of life reports as well. It also is important to provide physical therapy to those in palliative care so that they can benefit from the tools, strategies, and supports to remain engaged and participate in the remainder of their life. So for our evaluation of the pediatric patient, we want to take a full medical history, including birth history and developmental milestone history. So this means, when did they start walking? Did they crawl? Were they delayed at any milestones? Did they skip any milestones? It's important for us to know all this information. If a patient is currently undergoing treatment, we must be aware of the most current blood levels, vital signs, and what treatments they are undergoing. 3 of the main blood levels that we look at are white blood cells, platelets, and hemoglobin. With the white blood cell count, we're going to limit aerobic exercise if there's less than 5,000 cells per millimeter cubed, and or if a fever is present. We are able to do light aerobic exercise and resistance exercise if the white blood cell count is greater than 5,000 cells per millimeter cubed. With platelets, we want to avoid aerobic exercise if there's less than 10,000 cells per millimeter cubed. We can do light aerobic exercise between 10 to 20,000 cells per millimeter cubed, and resistance exercises we can do if the platelets are greater than 20,000 cells. With the hemoglobin levels, we want to avoid aerobic exercise if there's less than 8 grams per deciliter, but we can allow for essential daily activities. And then light aerobic exercise, we can do between 8 to 10 grams of deciliters, and resistance exercise greater than 8 grams per deciliter. We also want to assess range of motion, strength, balance, pain, functional skills, and age-appropriate developmental skills. With our age-appropriate developmental skills, this depends on the child's age, but typically we want to look at jumping, balance skills, strength skills, stair negotiation, and coordination. When we're looking at a child's pain level, it can be difficult for them to verbally rate their pain on a scale of 0 to 10. So using the Wong-Baker-Faces pain rating scale can be an important tool for us to use, but also depending on the child's age, it might be unlikely that we can get a true pain rating if they're on the younger side. We also want to use appropriate outcome measures to take our baseline data at our evaluation as well as our follow-up sessions. Some popular outcome measures that are supported by research and that are easy to use are the timed up and go, timed up and down steps, and the 6-minute walk test. For the timed up and go, it's very similar to what we use with our adult population. The child seated is in a chair, and on the command go, they're going to rise to standing, walk at a normal pace for 3 meters, turn around and walk back to the chair and sit down. This is a timed measure, and the mean time for ages 8 to 14 years old is 5.2 seconds to complete this. The timed up and down stairs, we want to instruct the patient that on the command go, they're going to walk up 14 stairs and then back down quickly but safely. This is also a timed measure, and the mean time for ages 8 to 14 is 8.5 seconds. With both the tug and the timed up and down stairs, we can look at what their balance looks like. Are they leading with one foot only when going up and down the stairs, their gait mechanics, etc. So these are really helpful outcome measures. The 6-minute walk test is also very popular for cardiovascular endurance and assessing gait and balance, as well as overall endurance. Physical therapy intervention. We want to address the functional deficits noted, dependent on the type of cancer and the side effects from the treatment, as well as their overall deficits that they have. And with our younger patients, we're going to do this through guided play. So they're very different than our adult patients who we can give 3 sets of 10 for strengthening exercises and TheraX exercises. With the children, we want to guide them through play to make it more enjoyable, but also more functional for them. Most patients will undergo some sort of deconditioning. Therefore, it's important to improve strength and cardiovascular endurance if they're healthy enough to do so. In a study done by Kalekwi Sohi et al., it was shown that general exercise therapy can improve cardiovascular, respiratory, musculoskeletal, and metabolic functions, and it also may improve quality of life measures as well. During chemotherapy treatment, it's important for us to include ankle dorsiflexion stretches, range of motion, and strengthening daily, as foot drop is a common side effect. We also want to include balance and proprioceptive activities so that we can improve ankle strategies and the use of the vestibular system. We also need to focus on fall prevention due to decreased ankle strength and chemotherapy-induced peripheral neuropathy. In our outpatient clinic, patients who have a history of steroid or radiation treatment, we should be aware that there's an increased risk of osteoporosis and avascular necrosis in the long term. So it's important for us to screen for these signs and symptoms in our patients, And if we see any of these signs and symptoms, then we should limit jumping, hopping, and other high impact activities and refer out to a doctor. Patients undergoing stem cell transplant should continue with physical therapy, but therapy should focus mostly on maintaining range of motion and endurance, and we should use body weight exercises instead of weight training. Patients who are post-brain surgery, the primary goal of physical therapy is to assist the patient with positioning to prevent skin irritation, fall prevention, and family education. The physical therapist can assist with assistive devices, transfer training, functional mobility, balance, and coordination activities. Patients with osteosarcomas, PT is important pre and post-surgery, and we need to include exercises that involve range of motion, strengthening, and functional mobility. Here are some examples of activities that we can do with the pediatric population. For dorsiflexion, balance, and proprioception, we can do heel walking, or what we like to call penguin walking, lifting rings and placing them on the cones to work on the ankle dorsiflexion and also single leg balance. And then proprioceptive taps both forward, sideways, and backwards to again work on the ankle stability and reactions. These are some of my favorite things to use with the pediatric population. The first being the scooter, which can work on active dorsiflexion because they have to drive their heel into the ground to pull themselves forward. When also moving forward on the scooter, you can work on overall endurance, coordination, and hamstring strengthening. When pushing backwards on the scooter, you're getting more quad activation and can also work on overall endurance. With the tricycle, you're getting endurance, cardiovascular purposes, lower extremity strengthening, coordination and motor planning to pedal correctly. Obstacle courses are very big with working with our pediatric population, and you can customize them based on what needs to be improved. You can complete multiple rounds to improve cardiovascular endurance. In this picture, we have an agility ladder. You can do so many things with the agility ladder, working on endurance, jumping, coordination. You can also use these foam blocks. They have it set up as a balance beam, so working on forward and backwards balancing, ankle righting strategies due to the foam blocks that are there, jumping over hurdles or stepping over hurdles for proper gait mechanics, overall motor planning, and like I said before, completing this multiple times so that the child is getting endurance training as well. Blowing bubbles are also great for overall endurance and improving the respiratory system. As stated before earlier in the presentation, therapists can assist with transfer training. This can be either with a sort of lift device or manually by the therapist or the parent. This includes stand pivot transfers, sit to stand transfers, using a sliding board, etc. We also want to make sure, just like with all of our other patients, that we give a home exercise program and that the parents are active participants within this home exercise program. If you look at the middle picture, we have a parent performing a calf stretch on the girl, and this is especially helpful for those patients who are undergoing chemotherapy, as we want to make sure we maintain or even improve the ankle range of motion. If the child is older and more independent, we can also include self-stretching within their home exercise program, as seen in the pictures to the right. And again, this will give them more independence, more autonomy, and make them want to complete their home exercise programs more. A systematic review was done by Lanero, Bocanegra et al. That investigated the effectiveness of therapeutic exercise for children undergoing treatment for cancer. This systematic review had the selection criteria that included children under 18 years old who were undergoing treatment for cancer or malignant neoplasm, random control trials design, utilization of therapeutic physical exercise or TPE, and including physical and psychosocial outcomes. 7 studies were included in this systematic review. The review found that most studies showed that strength, fatigue, and quality of life improved after intervention, but the effectiveness differed between studies. The 6-minute walk test was used in most of these studies, and the scores also showed to be better in the experimental group versus control group. In conclusion, they found that TPE is safe, effective, and feasible for those undergoing cancer treatment. TPE on a psychosocial outcomes were not clear due to discrepancies in the data, and future studies should find more effective strategies to improve psychosocial function and should include muscle strengthening, physical fitness components to address skeletal and motor deficits. These are the references that I used that I found most helpful for this presentation. Thank you for your time today, and I hope you learned a little something about the pediatric population and cancer survivorship within this population.
Thank you, Dr. Jensen. Let's now bring in Dr. Chris Kotlik and Dr. Heather Olson. Dr. Kotlik is a certified brain injury specialist, and Dr. Olson is certified in lymphedema therapy. They'll discuss with us the evidence around modalities in cancer rehabilitation. Take it away, team.
Hello everyone, thank you. I will briefly be discussing the use of modalities in cancer rehabilitation. Cancer care presents with a staggering array of prognoses, differential treatment approaches, and patterns of metastatic spread. There continues to be a lack of consensus as to whether a history of cancer or active malignancy remains a contraindication for some modality applications. When developing a plan, symptom burden is primary, as well as patient goals and safety. Considerations for specific modality use include the type of cancer and treatment status. There are concerns for the compounding clinical conditions due to multi-organ compromise, including cardiorespiratory changes, neurologic concerns like cognitive impairment, neuropathy, hematologic concerns, lymphedema, as well as fracture risk. Here are some common therapeutic modalities. The thermal modalities include the use of cryotherapy and heat. Electromagnetic modalities include electrotherapy, the use of TENS, transcutaneous electric nerve stimulation, neuromuscular electric stimulation, functional electric stimulation, diathermy, laser, and light therapy. Mechanical modalities include the use of traction, compression, manual lymphatic drainage, garment use, as well as hydrotherapy. The acoustic modality includes ultrasound, and of course there's exercise. Additional interventions also include acupuncture and yoga. Cryotherapy can include ice massage or cold packs. Heat modalities can also include the use of paraffin wax, fluidotherapy, or thermal ultrasound and diathermy. Ultrasound can be delivered for the effect of heat production or non-thermally for tissue repair. Indications for the use of cryotherapy include pain reduction, edema management limiting secondary hypoxic injury, and facilitating muscle relaxation. Precautions include hypertension over the areas of open wounds, over a superficial nerve, irritated or fragile skin, and poor sensation. Contraindications include Raynaud's disease, urticaria, which is an abnormal response to cold producing hives. Cryoglobulinemia is an abnormal clumping of red blood cells hindering blood flow. Peripheral vascular disease over the area of regenerating nerves, and simply cold intolerance. In the systematic review by Ronconi in 2024, it was determined that the use of cryotherapy slowed the occurrence of chemo-induced peripheral neuropathy in patients with breast cancer due to the physiological effects of local vasoconstriction, a decrease in cellular metabolism, and the reduction of nociceptor sensitivity, as well as decreased nerve conduction speed. For the application of heat, warmth is associated with tranquility and relaxation. Superficial heat can travel up to a depth of 3 centimeters. It increases metabolic rate, increases heart rate, as well as cardiac output. The indications include pain relief, increased elasticity of tissues, decreased viscosity, and decreased joint stiffness. The precautions are for impaired lymphatic function, over scar tissue, skin fragility, decreased sensation, and cognitive impairment. Contraindications include application over normal malignancy, unmanaged tumor or active disease, irradiated tissue, severely impaired sensation, acute inflammation, and over areas of infection. Application of moist heat is considered safe in a region without active malignancy. It does aid in the administration of manual therapy. In Dr. Molce's review, these precautions and contraindications are for cancer survivors. Ultrasound is high-frequency mechanical waves delivered using acoustic energy. Ultrasound can be delivered to superficial or deep tissues depending on the frequency. 1 megahertz travels to deeper tissues from 2 to 6 centimeters. 3 megahertz, which is considered superficial, travels from 1 to 2.5 centimeters deep. Continuous duty cycle is a thermal application, whereas a duty cycle of 20% will be non-thermal. Non-thermal indications include soft tissue repair, regeneration, and increased protein synthesis. Indications for both thermal and non-thermal ultrasound include pain relief, tissue repair, and increased tissue extensibilities. Contraindications. This is from Dr. Molce's paper. Contraindications include individuals with cancer or history of cancer. In a systematic review from 2024, there was evidence to show that low-intensity ultrasound was proven effective in treating trismus and TMJ dysfunction and had a superior effect on pain and quality of life in head and neck cancer survivors. Additional contraindications include pregnancy, delivery over the eyes or testes, over the heart or growth plates, as well as over sites of active bleeding. Transcutaneous electric nerve stimulation. This is the use of electricity to reduce or modulate pain. There are different forms of TENS based on clinical needs. There is sensory stim with no visible muscle contraction, and then there is motor TENS. This can be burst or acupuncture-like, producing contraction. Sensory has more immediate pain relief, whereas motor addresses chronic pain and the pain relief is much longer. Precautions include over areas of impaired sensation, pacer or defibrillator placement site, and history of cancer. Contraindications include pad placement over tumor, active disease, over pacer site, or over open wounds. The research supports statistical improvement in chemo-induced peripheral neuropathy following treatment with TENS, as well as improvement in physical impairments. TENS for pain relief. These were the results of a systematic review that included 7 trials that demonstrated reduced pain levels as well as reduced intake of analgesic medications, both opioid and non-opioid. It's not recommended as standard use in the treatment of pain or with chemo-induced peripheral neuropathy, but the literature did provide tremendous support that it is safe and easy to use for patients with malignancy, as pain is the most common symptom associated with all cancers. But each patient is, of course, unique, and this needs to be discussed with the patient and the medical team. Using TENS for peripheral neuropathy. When using TENS, the pad placement is unique. Is the use of low-level laser. This is a picture of the LTU 904. It is FDA approved for the treatment of lymphedema. It delivers an infrared laser that operates at a wavelength of 904 nanometers. The wavelength penetrates into the tissue approximately 2 centimeters to produce a photochemical reaction. And this is a non-thermal response, and Heather will be discussing the use of this laser in our next segment. The goal of this modality is to soften tissues, prevent fibrosis, reduce limb volume, and stimulate lymphatic drainage. The physiologic effects of using laser are dependent upon the associated wavelength and amount of light energy absorbed. Infrared is absorbed by the mitochondrial cytochromes, and the visible red is absorbed by myoglobin and hemoglobin. The precautions and contraindications that you see here are broad spectrum, as there are several classes of laser that are not touched upon today. In conclusion, there is so much to consider. where someone is in their recovery, are they newly diagnosed, undergoing treatment, are there post-surgical concerns, or is someone in need of comfort care? These are all considerations that need to be discussed as a team. A diagnosis of cancer is always considered a precaution, if not a contraindication, for some therapeutic modalities. Over the years, there's been more and more research, but of course more is needed. And the common denominator in my literature review is that exercise interventions reduce the negative impact of treatment-related symptoms and improve overall function and quality of life. Heather will now discuss in detail the use of the low-level laser and other adjunct modalities to treat lymphedema. Thank you.
Thank you to Chris for the great overview on modality use in cancer rehabilitation. In this part of the presentation, we're going to delve a little bit deeper into discussing current evidence supporting modality use in addressing cancer-related lymphedema and share research on how low-level laser and kinesiotaping can be applied across various cancer populations. I think we are all very well aware that cancer treatment has a wide range of side effects. This is really just to show that cancer-related treatments can affect someone from head to toe. So there is a lot of research out there on different modality use in addressing these side effects. For the sake of time, we are just going to focus on lymphedema and modality use to treat it. So the gold standard for the treatment of lymphedema still remains complete decongestive therapy, which is also known as CDT. It includes exercises, skin care, compressive bandaging, and manual lymphatic drainage. And in phase 2 of that, for long-term use, would be compression garments. The modalities that are in evidence and being studied are rarely used in isolation and used in conjunction with this type of therapy, and that's how they've been found to work best. So low-level laser and K-tape in conjunction with complete decongestive therapy help to decrease pain, decrease swelling, manage scar tissue and fibrosis, and promote functional range of motion and mobility, which will, in essence, help with quality of life. The pictures shown here are just showing how someone with head and neck lymphedema may also have a fair amount of fibrosis and scar tissue. So rarely there's just one issue going on with somebody. The middle picture is a low-level laser that we use in our clinic. It's a Rayon core, and it is FDA approved for lymphedema and cancer treatment, and it is, as of now, the only one. And this is just a kinesiotape pattern you might use for head and neck swelling, taped in a lymphatic pattern. So before getting into some of the research, I'm just going to quickly review low-level laser therapy and kinesiotaping effects, especially on lymphedema. Low-level laser therapy is a cold laser. It's non-invasive. It impacts cellular changes, which promotes lymphangiogenesis, inhibits formation of tissue fibrosis or softens fibrosis, improves inflammation. It's also known as photobiomodulation when you look at it in research. The wavelength of 904 nanometers is what we're going to use and what we use in the clinic, although there are many different kinds of lasers and many different parameters used throughout all of the research articles. Kinesiotaping is applied to the skin, and it gently lifts the skin and allows space for lymphatic flow. So it reduces fluid congestion and decreases the occlusion really under the skin. It softens the fibrosis and it improves pain. After cancer-related treatment, the prevalence of lymphedema remains pretty high among all cancer populations. 1 in 1,000 Americans will develop secondary lymphedema. An elevated BMI, low activity levels, whether they've been through chemo and or radiation, how many lymph nodes were taken during surgery, all may affect this number. 1 in 5 women who survive breast cancer will develop some extent of lymphedema, which is why it's so important to watch and prevent. For head and neck cancer, over 90% of patients will experience some form of internal, external, or combined lymphedema, with half of them having some form of fibrosis. And 37% of women who were treated for gynecological cancer had a measurable evidence of lymphedema within 12 months post-treatment. It just goes to show that modalities are being researched very heavily. A lot of times once you're diagnosed with lymphedema in a certain stage, it's not curable and people have to live with those side effects. So finding evidence-based research to support modalities that can be used to manage these side effects are really, really important right now. In terms of the research around treatment of post-mastectomy side effects with modalities, lymphedema really is kind of a central focus. So in one study that compared kinesiotaping, laser, and manual lymphatic drainage as 3 separate techniques used before multi-layer bandaging and exercise and education, skincare as part of a lymphedema treatment as a whole, it was found that kinesiotaping and laser were more effective in volume reduction and pain reduction than manual lymphatic drainage, but all of them elicited a positive response. Just kinesiotaping and laser were a little bit better. In another study, it was also found that laser therapy 3 times a week that was targeting the axilla was reducing symptoms of breast cancer-related lymphedema. Axillary web syndrome is another side effect, and it can sometimes go hand in hand with lymphedema, sometimes it's alone. Either way, it is a buildup of scar tissue in the axilla, could go to the elbow, it could go to the wrist, and it can be pretty restrictive for range of motion, which inhibits the exercise process, which we really need to treat lymphedema. So if there is cording present, it has also been shown that low-level laser therapy can improve range of motion, decrease pain when used with traditional therapy and medical care. And just another side effect is phantom breast pain. This picture kind of shows just how much scar tissue, and there's cording, and there's probably swelling, and also you're missing a part of your body. So there can be a lot of pain after the surgery. And another article showed that low-level laser therapy can improve shoulder range of motion, quality of life, and phantom breast pain post-mastectomy. So these are the modalities used in a lot of those studies and what we use in the clinic. Multi-layer bandaging is that first picture. The second picture is the device that we use in the clinic, and it's targeting the axilla, and typically there's 17 to 20 points. You can hold the laser there for about a minute each, and then that would be the treatment. You could also target the lymph node group at the elbow. And kinesiotaping on this person is taped in a lymphatic pattern with the anchoring being closest to the lymphatic node groups. So this is a photo of a patient that I treated recently who has pretty significant lymphedema and fibrosis in her arm. So it was maybe 7 minutes of laser. I did it on her forearm, her elbow, and her dorsal hand, and her fingers. And then I did lymphatic drainage, and you can just kind of see, I hope you can see, the tissue texture and just how relaxed her hand is and how that might translate into function. So that kind of just drives the point home that the laser is effective in softening the tissue, and it really helps in those smaller areas on the fingers. So breast cancer related lymphedema gets a lot of attention, but head and neck cancer and its side effects are also severe and pretty common. So a few articles that I found just relating modalities to head and neck cancer side effects: standard lymphedema therapy with kinesiotaping and advanced pneumatic compression devices, which is a lymphatic pump, appear safe and beneficial. Oral mucositis, dermatitis, dysphagia, xerostomia, trismus, head and neck lymphedema are all complications that can be addressed in some way, shape, or form with low-level laser therapy. There are a lot of articles out there and a lot of positive effects. However, the numbers and the parameters vary quite widely through all of the research. So most of the research is stating that more research has to be done to really nail down specific parameters for treatments. And also kinesiotaping is a viable option for myofascial pain syndrome after neck dissection. So kinesiotaping and low-level laser therapy can really be applied to head and neck cancer side effects as well. These are just photos of some of the modalities. This is the pump. It's also known as an advanced pneumatic compression device, kinesiotaping in a lymphatic pattern, compression garments, and just a picture of lymphedema to show how significant it can be for swallowing, eating, speaking, and pain. There's a lot less research on chronic pelvic lymphedema and modalities. However, low-level laser therapy was found effective in one case study in decreasing tissue tightness and swelling in the genital and abdominal area with chronic fibrosis and chronic lymphedema. So just to summarize, in addition to an established therapy routine, adjunct therapies and modalities such as low-level laser and kinesiotaping can be effective to improve swelling, range of motion, pain, and inflammation in head and neck cancer population, pelvic lymphedema population, as well as breast cancer-related lymphedema. But further research needs to be done to specify parameters, as they vary very widely in the research right now. And you would always discuss with a treating MD prior to the use due to the question for self-proliferation over untreated cancer. Thank you for your time. I hope you enjoyed.
Thank you both very much. It's now my pleasure to introduce Dr. Michael Erdek, who's the founding director of pain management at Northwell Health Cancer Center and an associate professor at Zucker School of Medicine. Welcome back.
Good morning. Can you guys hear me okay?
Yep.
All right. Okay, we're going to go into full screen mode, or are we good as is?
Give me a second, Dr. Erdek.
Sure, no
I'm just
problem.
pulling
Make
this up.
sure we're saying the same thing. Okay, we're good?
Yes, you're good.
All right, thank you. Okay, good morning. So it's a pleasure to be here with you this morning, and I'd like to thank the conference organizers for the opportunity to speak with you. I was asked to give an update on intrathecal analgesic therapy in the treatment of advanced cancer pain. And so let's go ahead and dive in. Next slide, please. So just by way of disclosures, I have no relevant financial or consulting relationships with any entities relevant to the presentation. And to be clear, the use of any intrathecal analgesic medication other than morphine, ziconotide, or baclofen is considered off-label use. Doesn't mean that they're not commonly used, but I need to disclose that they are considered off-label. And then finally, if I've included any pictures of equipment, they're purely there for purposes of clarification and teaching and do not constitute any sort of an endorsement for that particular manufacturer. Next slide, please. Okay, so I'd like to dedicate the first part of my talk to a little bit of background. Some of you may have a lot of familiarity with intrathecal therapy. Some of you may have very little. And then the second part will be the updates that have come across recently in the last couple of years. So many of you may know that the burden of cancer pain is that approximately 55% of patients undergoing active treatment have some sort of prevalence of pain. And this importantly includes almost 40% of those that are in remission. So when I teach the fellows, I teach them that this is not just a practice that deals with people with active cancer. And in fact, I have many patients who do not have active cancer, but who are dealing with the pain of the sequelae of those treatments. So it is a bit of a double-edged sword. And that number jumps up to almost 70% in those with advanced metastatic or terminal disease. 41% of ER visits by patients with cancer identified pain with some sort of diagnosis at that time. And to be clear, liberal systemic opioid use is still the standard of care. So we're going to talk about kind of raising the level for what happens when opioids don't work, but please don't misunderstand that I'm advising that everybody with cancer pain needs to run out and get a pump, because that's not true. Next slide, please. Okay, so if we look across the board, all comers, about 70% of patients with cancer will have some sort of pain. And this varies, as you may know, with pancreas and bone tumors being amongst the most painful. And if we look at the right of the diagram, we see things like breast, bloodborne diseases, and prostate much less so. So there's a variance, but about 70% across the board. Next slide, please. Now, when we talk about discontinuation of opioid therapy, discontinuation in this sense means either having to change opioids or change opioid strategies. And that's almost a quarter of the patients that you're going to have on opioids. So this is not insignificant that some sort of side effect or some sort of lack of efficacy is going to cause you to make a change in their opioid therapy. 33% of that 1/4 of patients required additional opioids. So for example, you may have someone on short-acting oxycodone, and you may have to add a long-acting like a fentanyl patch or an MS-Contin to provide more around-the-clock coverage. 16% required opioid rotation. You may be familiar with this strategy where we simply change the quote-unquote flavor of the opioid, the type of the opioid, and that in fact may be beneficial. Looking at different types of opioids, approximately 50 to 60% of them are going to have some sort of issue with the patient. Now, some of these, quite frankly, can be overcome. You know, if someone has pruritus, we can give Benadryl, for example. If someone has constipation, we can give stool softener or a promotility agent. So once again, not everybody who has an opioid side effect needs a pump. Next slide, please. The WHO cancer pain ladder has gotten a lot of press, not all of it positive, as you may know. And the hypothesis when this was put together was that approximately 10% of these patients would need over-the-counter stuff like NSAIDs, acetaminophen. Approximately 75% were thought that they would kind of plateau out on step 2, which is weak opioids. That is certainly not the case in my practice. My practice is much, much more skewed towards step 3. Strong opioids, sometimes intermittent dosing, sometimes around-the-clock dosing. Those who refer to people like me, well, almost 90% are going to be either palliative specialists or oncologists, which is not surprising. And then occasionally about 10% of patients will come from other pain doctors. Doctors who are kind of stymied by what's going on or who don't have a lot of experience with some of the more sophisticated cancer interventions. And that gives you a sense of where these patients come from referral-wise. Next slide, please. So what is in fact step 4? We've discussed the first 3 steps, but that is where your specialists come in. Now, palliation can be done in many different ways. It can be done with RT, surgery, chemo, and they can be done by obviously the specialists who have that expertise. But when we need to step up to neuraxial or nerve interventions for patients who are just refractory to these opioids or having dose-limiting side effects, they can be done by people like orthopedics, neurosurgery, IR, or pain specialists. When we talk specifically about pumps, the best data that we have suggests that it becomes cost-effective given the upfront cost of putting this in for patients who have approximately a prediction of 3 months of survival. Now, you may smile when you hear this because you know as well as I do that survival is very, very sort of unreliably predicted. So we do our best, but we do have some sort of, I would say, moral and fiscal responsibility to the healthcare system, not to, for example, put a pump in somebody who is expected to survive a week or two. That would be inappropriate. Next slide, please. Okay, so the deal with pumps is, as I tell my trainees, you get much more bang for your buck, right? When you give something orally, transdermally, even IV, the volume of distribution of the body is such that that is going to be distributed sort of very inefficiently throughout the body to get to the receptors where we want it to get, and hence you tend to see many side effects. When you give stuff IT, as I'll show in a study that I'm going to present, it's not completely without systemic side effects, but it is much more targeted, and that therefore lower doses can be given with more efficacy and fewer side effects. Next slide, please. So once again, this is not a endorsement, but it is provided by Medtronic, and this is simply to show you the hardware that's involved with making this decision. So there is the pump itself, which you may or may not know is about the size of a hockey puck. They keep getting a little bit smaller, which is a good thing. The catheter itself, which is a reinforced silastic device to prevent compression, which goes intraspinally. The programmer, which I use, which is about the size of an iPad. And then the programmer that the patient may use, which is about the size of a cell phone. Importantly, as you may know, many of these patients will need MRI surveillance to study their disease, and these systems are compatible with anywhere from 1.5 to 3 Tesla MRI. You do want to likely get somebody to interrogate it post-MRI. Usually I'll share with you that they're fine, but in the rare occasion that the MRI adversely affects the pump, we obviously don't want that to be the case. Next slide, please. Okay, so nothing is a panacea and nothing is perfect. So I would be remiss if I didn't present this slide. Things happen when you put in pumps, and this is one reason why we don't just put them in all the time. So things can go bad with surgery, infections, spinal fluid leak, things like that, bleeding, device complications. The catheter can leak, it can become occluded, hopefully not too often, or it can migrate. And then finally, we know that these pump batteries are eventually going to run out. They don't last forever. So you may get 5, 7 years out of it, but the pump itself may need to be replaced. And in some cases, that's not a bad thing because that means your patient is still surviving. And so I guess that's a positive spin on that one. Next slide, please. Okay, so now that we've covered some of the basics, I'd like to present a couple studies that have come out within the last couple years. So the first one is by Brogan and colleagues. It was published in ANA about 4 years ago. And what he did is he looked at serum opioid levels and clinical outcomes in patients who had cancer pain that got IT therapy. Next slide. So this was a relatively small study, about 50 patients, patients were about 55 to 60 years old. Most of them, as you can see, had stage 4 cancer. And you can see they were on a whopping oral morphine equivalent at the time of implant of about 375 milligrams daily. So not trivial. It was about 2/3 male to female. And you can see a pretty even distribution of different cancer types there. There's sort of this basket category at the end that threw in a lot of visceral cancers, but all cancers that you see there were kind of relatively equally represented. And about 8 of the patients, so not insignificant, 15%, were actually requiring IV opioids. Next slide. Okay, so what did they find? So we covered the mean dose pre-implant. At 4 weeks out, which was the first data point, about almost 90% of patients, even those on IV opioids, were off of all non-intrathecal opioids. The mean intrathecal morphine dose at 4 weeks was just shy of 5 milligrams. You can see there was a bit of a range there. And about 50% of patients had undetectable levels of serum opioids. So that doesn't mean all of them, but a fair number of these patients were on these, IT morphine, and it was not perceived systemically by these serum tests. The next data point was at 8 weeks out, similarly, a little over 90% off of all non-IT opioids. Dose range did escalate a little bit, and that's important to present because you can see that even intrathecally, we still develop tolerance to opioids. So this is not some sort of magic rainbow where patients don't develop tolerance, and you do have to escalate IT doses. And that's not without implications because there are granuloma risks, which is an entirely separate talk, but at least know that much. Once again, about 60% of patients with undetectable levels of serum opioids. The bar graph on the top is a bit misleading, I confess. 59% is not twice 53%, but you can see those numbers represented at 4 and 8 weeks. The lower right-hand corner graph may be difficult to perceive the color differences, but the top of the bar is sort of a dark green, and the bottom of the bar is a grayish blue. So if we look at constipation as one of our sort of metrics, we can see that the gray is not at all or a little bit. It was 60-40 constipated before we started. At 4 weeks, it was 80-20 non-constipated. And at the second data point, it was 60-40 non-constipated. So one way of measuring the effect of the implants. Next slide, please. The next study I wanted to present to you was published by the late Lisa Stearns and her colleagues in one of the JAMA journals about 5 years ago. Next slide, please. And what we're going to look at here is the outcome on the healthcare system cost utilization of implanting pumps in patients with cancer. So what Stearns and colleagues did is they looked at a large commercial payer database, and TDD is targeted drug delivery, so that is IT pump plus CMM is comprehensive medical management. So basically patients who got pumps plus they could still get opioids versus those patients who did not get pumps. And this was a huge database review over about 6 years, and you can see the number of patients that were contained in that data set. Next slide, please. Okay, so what she looked at were a couple different metrics. We looked at the number of inpatient visits that occurred over 2 months, 6 months, and 12 months. The pump group is the blue bar, which is on the left. The non-pump group is the green bar, which is on the right. We also looked at the number of emergency department visits, and we looked at the total number of inpatient days across all admissions. Now, what we can see is those patients that received pumps, and keep in mind this is retrospective, we can see it's anywhere from a half to a third of those patients that did not get pumps. Now, let's be super clear. I know this is a very sort of educated audience. There are many more things in cancer patients that bring patients to the ER other than pain. So I'm not saying pain cures cancer or eliminates cancer side effects. This is simply an observation of occurrence of these sorts of admissions or visits in patients who did or didn't have pumps. Now, if we look back at the data I presented initially, showing how common pain is, I don't think it's inappropriate to conclude that that may have played a role here. But I think that it's important to note that at least over a huge database review, those patients that had pumps were considerably less likely to come to the ER or to be admitted to the hospital. Take that as you will for what it's worth. Next slide, please. So let's talk a little bit about the dollars here. Once again, 3 data points, 2, 6, and 12 months. And you can see there was some attrition in the study if we look at the number of patients that were in the sample size. TDD, once again, is the pump group. However, if we look at cost savings, so at 2 months, there was about $15K in favor of the pump group. If we look at 12 months, it was about $63K. And so if we graph that out on the right, we can see that the commercial payment savings of those who received pumps versus those who did not actually escalated over that 12-month time. Once again, pumps are not cheap. You're talking $30,000. That doesn't count anesthesiologist costs, OR costs. It's a lot of money to put one of these in. They also require refills, which cost money as well. So this is why I go back to my point earlier. We don't just throw a pump in every cancer patient, even though we feel like we want to be compassionate and we want to respect the data and so forth. But I do think it's helpful to look at Stearns's paper and look at some of the cost savings that were associated over time with this group. Next slide, please. And finally, I think I have 2 minutes left. The polyanalalgesic consensus guidelines. So this is a group that meets about every 7 to 10 years. I've been on a couple of these in the past. The new guidelines just came out, and I'd like to review some of the new data. So this is a group of 20 to 30 specialists who put forth recommendations on the appropriate use of pumps in their medications. Next slide, please. Okay, sorry if this one's a little bit blurry. So what the group did this time is they really split into those patients with cancer pain with limited life expectancy versus those, we'll say 6 months or less, versus those with more than 6 months. Once again, we're getting into prediction here. And the primary difference that I want to bring to your attention is that it's opioid heavy early. So we see morphine, hydromorphone. I like hydromorphone, bupivacaine. I feel like the opioid treats the nociceptive pain, the local anesthetic, the neuropathic pain. But we see things like ziconotide. I don't know if you guys are familiar with that, but it's a intrathecal only N-type calcium channel blocker that's super nuanced, super narrow therapeutic window and cost intensive. That's lower down. But if you go to the next slide, please, we see that once we get above 6 months, we see that ziconotide now has moved up to a higher level on the algorithm. So I think the reason to present that is not to get too deep into the weeds here, but just simply to show that we can get into more nuanced, perhaps more expensive medications with patients who have longer life expectancy predicted. Next slide, please. Once again, super busy slide, but if you look down at ziconotide, you can see that the factors complicating use, which is the right-hand column, cost is an issue. And also importantly, this is largely not covered by hospice in the United States. So if you have a hospice patient, it's probably inadvisable to place ziconotide in the pump. I talked a little bit about this earlier. If we go up to the opioids on the right-hand side, this granuloma and neurotoxicity is potentially a factor once we escalate these doses. Okay, and then we use all kinds of crazy stuff like clonidine. Baclofen is approved for spasticity, but it can actually be added as an adjuvant off-label for analgesic because of its GABA effects. Next slide, please. Trialing, I don't want to get into this too much because we're short on time, but what practitioners who do what I do have to do is make a decision of how you want to predict a response to a pump before you put it in. Some of us do single shot trials where we do an injection of medication under sterile conditions into the CSF space. Other doctors will place a catheter, which requires an inpatient admission in some cases. Super, super expensive, frowned upon by hospital administrators. Others simply put in the pump and don't trial. So it's really a question of prediction versus maybe being a little bit more cost responsible. There's a wide variety of opinions on this in my community. I will say that there is more of a push towards non-trialing now than there has been in the past. Next slide, please. The point of this here is simply to show that the catheter tip in the CSF needs to go relatively close to the area that I'm trying to treat. The medication does not diffuse out, even if it's really hydrophilic like morphine, very far from the catheter tip. And we have a lot of animal studies that show this. So the point here is catheter tip needs to go close to the desired intended area of effect. Next slide, please. And these are just different starting doses. I put this in here simply to show you that these are super, super, super small doses relative to what you would give somebody systemically with opioids. So once again, you get an awful lot of bang for your buck. We're talking like microgram doses here to get this effect in the CSF. Next slide, please. Okay, so the take-home points are targeted drug delivery, which is IT pumps plus medical management of cancer-related pain, can be considered for both short-term predicted and long-term survivors for whom oral opioids are inadequate or produce intolerable side effects. That's the #1 take-home point. We do have clinical data which support a positive risk-benefit ratio for targeted drug delivery as a treatment for cancer pain. We also have additional clinical data which demonstrates benefits in transitioning from systemic to intrathecal opioids for cancer pain management. And then finally, in the one study I showed, there were a significant benefit in terms of healthcare utilization cost at 1 year in patients who were given pumps versus those who were not over a 1 year period. So thank you so much for your attention. And once again, thanks to the organizers for the invitation.
Thank you very much, Dr. Ardak. And it looks like, your background looks like you're right in the procedural room.
I don't get too far
Thank you
from the
so
OR.
Thank you so much for taking us through that. Also, just as you look at the time, it's 11:39 now. Let's actually, as per schedule, let's take a very quick stretch break, guys, and we'll resume at 11:45. Thank you. Welcome back, all. Let's resume with Dr. Jasmine Zhang, who is an attending physician in the Physical Medicine and Rehabilitation Department at Perelman School of Medicine, University of Pennsylvania. She also serves as the Program Director for the Cancer Rehabilitation Fellowship and the Director of Cancer Rehabilitation at UPenn. Dr. Zhang, thank you for taking the time to join us today. Take it away, please.
Good morning. My name is Jasmine Zane. I am the Director of Cancer Rehabilitation at the University of Pennsylvania. And today I will be speaking to you about leveraging lymphedema surveillance and imaging techniques in cancer rehabilitation. I just first want to say I'm so happy to be here. Though we in the cancer rehab community may commonly encounter lymphedema and feel that we have a good understanding of the disease, lymphedema and lymphatic diseases in general is poorly understood. I have patients who have lymphedema or lymphatic diseases stay at our hospital and come to me later and say, man, I wish more people, more clinicians knew what lymphedema is, knew how to treat it. How can we make that happen? And it's true. Knowledge of the lymphatic system is unfortunately eons behind our knowledge of other organ systems. And it wasn't until recently that the NIH designated lymphedema and lymphatic diseases as areas necessitating more research. And so today, I'm incredibly excited to be able to talk to you about this very important topic. I have no disclosures. Today, I will first review cancer-related lymphedema epidemiology and a brief overview of lymphatic anatomy to better understand just the complexity of the system, and then delve into the imaging modalities for early detection and for evaluation of treatment response. To review, cancer-related lymphedema makes up a large proportion of all lymphedema cases in the United States and in the world. It's estimated that approximately 2 to 74% of breast cancer patients will develop breast cancer-related lymphedema, 8 to 45% in the gynecological and urological cancer population, 71 to 90% in head and neck cancers, and 2 to 29% in melanoma cancers. Lymphedema is not just a number or a percentage. There is a huge psychosocial impact of lymphedema on our patients who suffer from the disease. I think about many conversations I've had with patients in my own clinic and some of the stories that they've shared. Some have said, I can't bandage my arm when I'm working, so I stopped going to therapy. Lymphedema has been worse than my cancer. I don't want to deal with this every day. And I was told the treatment will cost me $800, and I can't afford that. And financial toxicity is very real when we talk about lymphedema treatment. Within 2 years after breast cancer surgery, those who have lymphedema versus those without lymphedema had about a $10,000 extra medical cost. In addition to that, there were 6 times the number of all-cause hospitalizations in those with lymphedema compared to those without in one study that looked at financial toxicity in patients with breast cancer-related lymphedema. If we were able to diagnose and treat lymphedema early, Well, in 2012, Stout and colleagues estimated the cost of lymphedema treatment if utilizing a prospective surveillance model versus the traditional model. In a prospective surveillance model, we are identifying and acting on lymphedema as early as possible. It was found that the total cost for a prospective surveillance model would be $636.19 versus the traditional model, which would cost $3,124.92. Quite a big difference there. So why aren't we all doing prospective surveillance yet? Well, there's several answers for that. But part of the difficulty lies in access to diagnostic options that will allow us to actually detect lymphedema subclinically early. Up until recently, many people utilize tape measurements, physical exams, and sometimes things like water displacement, or especially in research settings, spirometry. And unfortunately, none of these allow us to really easily detect lymphedema early or early enough. I could talk more about the lymphatic system anatomy, but I think that'll take another hour. So for now, I just wanted to briefly show you some of the complexity of the system through some photos and diagrams. This shows the superficial lymphatic vessels in the upper extremity here. It shows a cadaver hand and antecubital fossa with the thread-like superficial vessels seen in green and yellow. This shows the superficial lymphatic pathways in the leg and variations of that. Not pictured is more of the deep lymphatics, and also not pictured here are the central lymphatics, such as the thoracic duct and the cisterna chyli, all of which can be affected and damaged in patients with cancer-related lymphedema. And this brings us to the 5 imaging modalities I will focus on today and their roles in detecting lymphedema, including opportunities to detect them early. I will talk about bioimpedance spectroscopy, ultrasound, lymphoscintigraphy, indocyanine green, and MRI lymphangiography. So first is bioimpedance spectroscopy, which is a non-invasive monitoring tool that will allow us to measure and monitor fluid status and tissue composition in our bodies through the use of high frequency to lower frequency current flows. There are mathematical models that have been validated that are utilized to calculate the actual tissue and fluid measures. There's no steep learning curve, and it's very, very easy to use and quick to use. Spectroscopy has actually been validated to detect lymphedema when subclinical. And in fact, it can detect fluid changes in as little as 36 milliliters, which is about 2 tablespoons. It's been validated against lymphoscintigraphy, and it's 80% sensitive and 90% specific in detecting subclinical lymphedema following breast cancer surgery. I'd like to briefly share the PREVENT trial, which was a large landmark randomized controlled trial study that came out a couple years ago that assessed lymphedema prevention. They looked at 1,200 patients with breast cancer who underwent breast surgery, axillary treatment that included axillary lymph node dissection, radiation to the axilla, radiation or taxane-based chemotherapy. And these patients were randomized to either prospective surveillance by tape measure or by bioimpedance spectroscopy. And for those that were determined to have subclinical lymphedema by either measure, they were prescribed a compression sleeve and a gauntlet, which they wore for 12 hours a day for 4 weeks. And the primary outcome of the study was the rate of post-intervention progression to needing complete decongestive therapy. The study found significantly lower progression to chronic lymphedema with an early detection program using bioimpedance spectroscopy versus circumferential tape measures. In addition, what they noted was that bioimpedance spectroscopy was more specific for lymphedema detection than tape measure was, as the former had fewer triggers and longer times to intervention triggers. In addition to bioimpedance spectroscopy's use in detecting subclinical lymphedema, it appears that it also has benefits in predicting treatment response. In 2019, Yusunaga and colleagues looked at 30 patients who had unilateral lower extremity lymphedema who actually underwent lymphovascular surgery to treat their lymphedema. These patients were evaluated by bioimpedance spectroscopy, and they found that the patients had a reduction of about 45% in excess water in the affected leg at 6 months follow-up after surgery. What they also noted was that there was a difference between preoperative bioimpedance spectroscopy measurements from the affected and unaffected legs that could actually predict volume reduction with LVA. So that was pretty cool. Of course, bioimpedance spectroscopy is not without its limitations. Since it depends on the water content of the area that you're studying, advanced and more fibrotic edema, so later stages of lymphedema, may not be diagnosed properly with bioimpedance spectroscopy. In addition, some have found that has lower specificity and sensitivity regarding diagnosis compared with indocyanine green, which I'll talk about shortly. And in addition, you aren't able to utilize bioimpedance spectroscopy to look at a specific area of a limb. For example, one area of the arm may have more swelling than another, but bioimpedance spectroscopy is not going to be able to separate that out for you. Despite these limitations, bioimpedance spectroscopy is clearly very promising in detecting early lymphedema. And in fact, in 2023, the National Comprehensive Cancer Network survivorship guidelines recommend actually, if available, utilizing bioimpedance spectroscopy for lymphedema screening. Now let's switch to ultrasound, which has rapidly become a promising tool in analyzing for lymphedema in both surgical and non-surgical settings. Dermal thickness can be measured on ultrasound, and what we found is that thickness, along with the echogenicity of the subcutaneous tissue, correlates really well with International Society of Lymphology clinical staging. In 2014, Suhiro and colleagues demonstrated that you could actually utilize ultrasound to tell the difference between dependent lower extremity edema versus legs with lymphedema. And they found that in dependent edema, there were echogenicity predominantly in lower portions of the limb, and there was really no difference between medial and lateral sides, versus even in early stage lymphedema, there was echogenicity increase in both the upper and lower legs, and that there was echo-free space that increased in all parts of the leg. Now, in subclinical lymphedema, a small amount of extra fluid in the interstitial space of the papillary reticular dermis can be found, but that does not usually correlate to a volumetric change in the extremity that can be detected. However, if you put an ultrasound probe to that area, you will be able to determine that there is a difference from the usual trilaminar structure of the dermal epidermal complex to one that has an hypoechoic dermal strip right here of edema. And in fact, if you look even deeper in the subcutaneous tissue, you may actually be able to see the dilation of the deep lymphatic collectors. In my opinion, I think ultrasound can sometimes sound deceivingly easy. And I just want to bring up a few limitations with use of ultrasound. There's a lot of variability between users, and specifically the amount of pressure that's applied to the probe with ultrasound can affect the tissue thickness. And so, in that same vein, if someone has a high BMI and high amounts of subcutaneous tissue, or if someone has early stage lymphedema and the findings are not very obvious and subtle, it may really affect the reliability of this technique. And especially for an early user, a less experienced user, they may have more difficulty identifying relevant structures versus someone who has more experience. Variation of ultrasound that I did want to mention quickly is ultrasound elastography, which generates a shear wave into the tissue during ultrasound through the use of a shaker. And greater stiffness and thickness values in the cutaneous and subcutaneous layers of a limb affected by lymphedema is seen compared to someone without lymphedema, compared to a limb without lymphedema. Now, for that reason, this may be less reliable in earlier stages of lymphedema where you see less fibrosis. Lymphoscintigraphy has actually been around for a very long time, and it utilizes a radio-labeled technetium sulfur colloid that's injected either intradermally, subcutaneously, or subfascially, depending on what you want to look at. And it can demonstrate the flow of lymph fluid in both the superficial and deep lymphatic pathways. Now, there's both qualitative and quantitative methods to analyze lymphoscintigraphies, and each gives you unique information about a limb. Qualitative methods are much more common, but quantitative methods are more sensitive when used actually in the diagnosis of lymphedema, especially in the earlier stages. This is an example of a lymphoscintigraphy, and here you have the anterior and posterior view of bilateral lower extremities. Here in the black box on the far left side, you can see the right leg and then the left leg. The right leg has the linear lymphatic vessels that shows normal movement of the tracer through the lymphatic system, versus on the left, where you really have difficulty seeing any movement of tracer proximally. Using lymphoscintigraphy, you can visualize uptake of tracer in the lymph nodes. You can see whether lymphatic ducts are linear, as you can see on this right leg, or absent, as you can see on the left, or sometimes even engorged. And occasionally you may also be able to see dermal backflow, and you can see it here in the white boxes in the left leg. Later during the study, that there is accumulation of the tracer in the subcutaneous tissues. Him and colleagues performed a retrospective study in which lymphoscintigraphy was performed between 4 to 8 weeks after surgery, after breast cancer surgery, in 201 patients who did not have lymphedema. And then they utilized quantitative lymphoscintigraphy via 4 methods. And there was a 1-year follow-up, and they analyzed the difference in quantitative lymphoscintigraphic methods between the non-lymphedema and lymphedema groups. What they found was that there was a higher probability of actually developing lymphedema in patients who presented originally with abnormal ratios of radioactivity between the affected arms and the normal axilla. In addition to predicting lymphedema development, lymphoscintigraphy can also be helpful in treatment and surveillance. In 2021, Kwan and colleagues used quantitative parameters to predict early and late surgical outcomes before lymphovenous anastomosis was actually performed in 17 patients. What they found that a high extremity uptake ratio in patients showed greater volume reduction than patients who had a low high extremity uptake ratio at 2 hours after lymphoscintigraphy. And then many years ago in 2002, there was a study that actually looked at radioactivity between a normal axilla and that of a lymphedema arm. And what they found was the radioactivity differences correlated with the percentage reduction in edema volume after lymphedema therapy in breast cancer patients. Lymphoscintigraphy, just like all the other imaging modalities we've talked about so far, have limitations. Their sensitivity and specificity variability due to differences in technique. There's no standardized protocol, and so depending on the institution, there may be differences in how they're reporting the data. And again, some people report it quantitatively, but most people are going to report mainly qualitative data. In much of the research that showed benefits in lymphoscintigraphy in early detection and in assessing treatment really depended on quantitative measures. In addition, as you could see from the imaging I shared, it does have poor image resolution, which can also make it difficult in interpreting the data. And finally, there's exposure to radiation, unlike bioimpedance spectroscopy or ultrasound. Indocyanine green lymphography is another imaging modality that's actually been utilized for a long time in a variety of non-lymphatic settings. In a lymphatic setting, we commonly understand ICG or have heard of ICG because of its use in sentinel lymph node biopsy procedures. What's really cool about ICG is that you're able to quickly visualize superficial lymphatic flow real time. There's no radiation, and you can look at the area of interest very quickly. So you don't have to wait for an MRI or a lymphoscintigraphy study to be done over a 45-minute to a 4-hour period. Unfortunately, it doesn't allow us to visualize lymphatics deeper than 1 to 2 centimeters below the skin. So you really have to keep that in mind when you're trying to analyze someone's lymphatic system using this image mode. Various patterns that you see in the limb on ICG will tell you the state of lymphedema. In those without any lymphatic issues, you will see linear fluorescence imaging. But as the stages of lymphedema progress, you're going to see things like a splash or stardust pattern, which shows us dermal backflow, which is that abnormal state of lymphatic circulation where the lymph will start utilizing the superficial system to rely more on the superficial system to move fluid rather than the deeper system. A study that was published in 2016 where patients were assessed with ICG in limb volumes before surgery and 1, 3, 6, 9, and 12 months after breast surgery for breast cancer. And what they found was that lymphatic dysfunction could be detected on ICG, utilizing the patterns that I discussed in the previous slide, before any volume changes were actually detectable. And then in 2022, a group did serial follow-ups of breast cancer patients before surgery, 4 to 8 weeks after surgery, and then 6, 12, and 18 months after radiation. What they found was also that ICG was able to detect dermal backflow patterns prior to any clinical presentation of lymphedema in 83% of patients. That's a lot. So what should you use, ICG or lymphoscintigraphy? Well, Figueroa and colleagues in 2023 looked at both primary and secondary lymphedema in extremities, and 50 limbs were examined by both lymphoscintigraphy and ICG. Of those 50, 37 were symptomatic, while 13 had asymptomatic limbs. What was really astounding was that lymphoscintigraphy missed symptomatic limbs 30% of the time, and lymphoscintigraphy missed asymptomatic disease 54% of the time, all compared to ICG. You can see here that in secondary lymphedema, which includes cancer-related lymphedema, the ICG detected 100% of symptomatic limbs versus 83% by lymphoscintigraphy. And then in asymptomatic limbs, ICG detected 60% versus 0 in the lymphoscintigraphy group. By lymphoscintigraphy, sorry. ICG really has a lot of wonderful uses when we think about treatment of lymphedema. It's allowed surgeons to look at the lymphatic system real time when they're making decisions in the OR. They can utilize ICG to confirm patency of anastomoses during a surgery and then in the post-op process down the road. And in the interest of time, I won't delve into some of the really interesting studies here, but there has been a lot of research that has utilized ICG to better understand lymphatic flow after things like axillary lymph node dissection. And what we found in these studies have really changed the way that we approach manual lymphatic drainage in therapy for treatment of our cancer population. I do want to briefly talk about MRI lymphangiogram, which is able to highlight edema, fat, and contrast agents. So of all the modalities, this is definitely the one with the most detailed visualization of the limb. There's no depth limitations like ICG and sometimes ultrasound. And we know that lymph has a high T2 relaxation time. So you can utilize various ways on MRI to highlight what you want to see. And what's really great is it can both image the peripheral and central lymphatic system. In milder disease, you will see subcutaneous lymphedema below the knee or elbow, but the infiltration doesn't increase fat volume or diameter, and the epifascial fluid is going to be less than 5 millimeters. But as a disease progresses, this will change, and you will start seeing increased fat volume, increased epifascial fluid, more diffuse spread of the subcutaneous edema. And there have been a few studies scattered demonstrating that MRL can be useful in assessing treatment response. For example, lymphatic cross-sectional areas are decreased after manual lymphatic treatment. And also there's improvements in backflow and the ability to visualize collateral lymph vessels in those who actually undergo microvascular lymphatic surgeries. MRLs are time-consuming. They're technically challenging in that they require specially trained staff who know how to perform the lymphangiogram, and also radiologists who are specially trained to interpret these complex studies. In addition, they are expensive. And unlike ICG, MRL is going to be much more difficult to utilize MRL to determine a lymphovenous anastomosis or to analyze neovascularization after a lymphatic surgery. So in summary, we actually have some promising tools in our toolbox to better detect lymphedema. Bioimpedance spectroscopy is good at detecting subclinical lymphedema, but requires some upfront costs to set up within a system. In addition, it may not be as useful in later stages when there's more fibrosis and less fluid. Ultrasound can as well detect subclinical lymphedema, but it's going to be more user dependent and has a learning curve. Lymphoscintigraphy, ICG, MRLs are going to be more invasive and more expensive to conduct individual tests, but can really provide some useful information independently or in conjunction with other methods. So the decision on imaging and what you will utilize in the clinical setting is really going to depend on your individual patient's characteristics, but also what's going to be available in the region where you practice. Some of these imaging modalities may require specialized personnel, training, and high costs sometimes upfront, which might make it difficult for you to implement one particular modality versus another. And finally, a combination modalities may in fact be helpful in certain circumstances rather than just one individual imaging type. And one last thing, as I conclude, thinking about the future, what's next? Well, I did want to mention artificial intelligence. There have been a couple studies that have come out discussing using AI and deep learning to develop ways to aid in both diagnosis and monitoring for lymphedema. So I think there will be more to come in the near future about this and its potential uses. Thank you.
Thanks very much, Dr. Zain. Now let's bring in two of our speech-language pathology colleagues from Northwell's Long Island Jewish Medical Center. Margaret Galligan and Danielle Cardinali will discuss evidence-based practice around head and neck cancer management.
Today we're going to be talking about advances in speech-language pathology in patients with head and neck cancer. Throughout the course of today's presentation, we're going to review the anatomy of the speech, voice and swallowing mechanisms, discuss the effects of radiation on these mechanisms, define the role of speech-language pathologists in head and neck cancer management, and review treatment goals and modalities associated with deficits seen in head and neck cancer. As a general overview of the anatomy and physiology of the speech mechanism, there are 4 processes involved in speech production: respiration, or the use of breath support required to generate the power needed to produce speech sounds; phonation, the ability for your vocal folds to generate a speech sound; resonance, the vibratory patterns occurring within the naso and oropharynx to produce sound; and articulation, which is the need for your articulators, such as your tongue, lips, and palate, to move intricately, precisely, and quickly to allow for intelligible speech sounds. In addition to respiration, resonance, and articulation, our ability to produce a voice meaningful for communication also involves a functioning phonatory system. Difficulty producing a voice would be diagnosed and treated as dysphonia. Air pressure is moved out of the lungs and towards the vocal folds by coordinated actions of the diaphragm, abdominal muscles, chest muscles, and rib cage. Vocal folds are moved to midline by voice box muscles, nerves, and cartilages. The vibratory cycle occurs repeatedly in a cyclical pattern of opening, vibrating, and closing of the vocal folds before a new cycle repeats. The rapid pulses of air created by repeat vibratory cycles produced voiced sounds, which is then amplified and modified by the vocal tract resonators, producing voice. This also encompasses loudness and pitch. The brain integrates auditory, somatosensory, and motor information to control speech production and allow for intelligible speech to be produced by the speaker and understood by the listener. This requires planning and sequencing of movements of the lips, tongue, jaw, vocal cords, and respiratory system. Difficulty with motor speech production would be diagnosed and treated as dysarthria. Any and all of the 4 subsystems may be impacted in these patients and are based on the location and staging of disease, surgical changes, and/or post-radiation sequela. Some areas speech pathologists will target when these systems are affected include improving strength and range of motion of labiolingual and mandibular structures, which can impact speech and swallow function, for example in trismus; improving resonance, use of alaryngeal speech in patients status post-laryngectomy; increasing breath support needed for audible communication; maximizing vocal fold movement and/or reducing strain required for optimal vocal quality; improving intelligibility or rate of speech; and reducing lymphedema of articulators and perilaryngeal musculature to allow for improved overall communication. In reviewing the swallowing mechanism, we want to make sure that we are looking at the oral, pharyngeal, and esophageal stages of deglutition. Any impairment or dysfunction in any of these 3 stages would be diagnosed and treated as dysphagia. Signs or symptoms associated with oral stage dysphagia include difficulty collecting, forming, or propelling a bolus within the oral cavity, weakness and/or absence of labiolingual, palatal, and/or mandibular structures. Signs or symptoms associated with pharyngeal stage dysphagia include difficulty in bolus progression within the pharynx, resulting in bolus residue, penetration, or aspiration; weakness and/or absence of the musculature at the base of tongue, posterior and/or lateral pharyngeal walls; reduced laryngeal excursion, epiglottic deflection, and closure of the laryngeal vestibule. Difficulty with the esophageal stage of deglutition would include difficulty in bolus progression within the esophagus into the stomach, reduced opening of the upper esophageal sphincter, esophageal motility disorders, and/or presence of strictures. In regards to the prevalence of dysphagia in patients with head and neck cancer, up to 28% of all head and neck cancer patients will complain of some type of dysphagia at initial presentation, with up to 50% of patients complaining of dysphagia once diagnosed with pharyngeal cancers. 45 to 75% of head and neck cancer survivors throughout treatment and post-treatment demonstrating long-term deficits with head and neck cancer. Effects of dysphagia can result in diet modifications to more restricted consistencies, need for alternative means of nutrition, such as a PEG or J tube or NG tube, Need for compensatory strategies or maneuvers to assist in safe and effective deglutition, such as a chin tuck or head rotation with PO intake, and social emotional effects on the patient as well as their family or support system. Therefore, the role of the speech pathologist in patients with head and neck cancer include the evaluation of the speech, voice, and swallowing function of the patient, development of a treatment plan to target any observed and/or reported deficits, educating patients and caregivers on the effects of head and neck cancer or radiation effects on the speech, voice, and swallowing mechanisms. We want to make sure we incorporate individualized exercises, compensatory strategies, or treatment modalities designed to improve communicative and/or swallow function. We work alongside multidisciplinary teams to ensure the patient is receiving optimal care from specialized departments. This can include members of radiation oncology, oncology, ENT, surgical teams, registered dietitians, social workers, dentistry, etc. Understanding of most recent evidence-based practices designed to promote optimal rehabilitative function for our patients is very important.
When thinking about formulating goals for the head and neck cancer patient, it is important to acknowledge and keep in mind that due to the variability in patient plan of care, patient response to treatment, and several additional factors, including patient compliance, our goals should be realistic and not necessarily restorative in nature. Rather than focus on a return to prior level of function, we instead seek to prevent decline, maintain an acceptable level of function and quality of life, with emphasis on maximizing both safety, in this case in terms of swallowing and eating, as well as efficiency, that is effective communication, appropriate ability to maintain nutrition and hydration, etc. As much of the current literature references, there is lacking evidence and expertise as to what is the best, most effective therapeutic approach in managing head and neck cancer patients with speech and swallowing issues. The good news is that current research trends are focused on not only standardizing our care, but highlighting some of the specific issues that are not necessarily speech and swallow related. For instance, patient compliance, decisional regret, psychosocial status, and showing the need to address the patient as a whole to maximize success at every level. There has been a tremendous push for prehab across disciplines in recent years, including our own. One of the earliest definitions of rehabilitation is a process on the continuum of care that occurs between the time of cancer diagnosis and the beginning of acute treatment, includes physical and psychological assessments that establish a baseline functional level, identifies impairments, and provides targeted interventions that improve a patient's health to reduce the incidence and the severity of current and future impairments. Our intent with prehab is to establish a baseline inclusive of acknowledging any chronic or pre-treatment deficits, make note of physical and mental, emotional health and well-being, do what we can to set the patient up for success and limit treatment burden, and give them the best chance of returning to the highest level of function. Research shows that various combinations of prehab in head and neck patients have shown to lead to declines in mortality rate, a reduction in swallowing related issues, a reduced risk of weight loss, as well as decreased hospitalization lengths. A typical prehab regimen consists of pre-treatment counseling, guiding patients in what they can expect in terms of changes to speech, voice, and swallowing function, educating the patient regarding the importance of maintaining good nutrition and hydration, staying on top of oral care, reviewing diet modifications if indicated, encouraging the patient also to self-monitor for clinical signs and symptoms of lymphedema. We also introduce a prophylactic exercise program consisting of exercises and stretches, maintaining strength and range of motion of the affected structures, as well as review of optimizing vocal hygiene and maintaining good breath support to avoid developing further damage to the laryngeal structures. And this is especially important in cancers of the true vocal cords. There is quite a bit of research that has been published in terms of what swallowing exercises to implement before, during, and after head and neck treatment. This chart is just one example of a proposed treatment program prescribed regardless of identifiable swallowing issues or formally diagnosed dysphagia. Exercises for the jaw, tongue, lips, pharyngeal musculature, as well as passive swallowing activities. Research is pretty consistent in showing a positive impact on swallowing and oral motor function in the short term, so 3 to 6 months post-treatment. Unfortunately, and this is a major issue across disciplines, there is no significant changes or improvements that are noted in swallowing function at the 2-year post-treatment mark. This further highlights the need for research to focus on late-stage effects of radiation and reconstruction and how they are impacting speech and swallowing function, as well as what we can include in our treatment to, at the very least, slow the progression of these adverse symptoms. As previously discussed, there are limitations to our prehab and swallow interventions. There is not one standard prescription, so to speak, as far as intensity and frequency of exercise is concerned. There are issues with compliance with therapy tasks during radiation treatment. The highest incidence of patients lost to follow-up post-treatment, overall inability to determine best practice, and again, even a lack of understanding of our true role. Are we trying to prevent or restore, or are we just there in support? Fortunately, we are starting to look at other factors in effort to optimize care across disciplines. A brief overview of trismus, a very common issue with our head and neck patients, whether caused by surgery, tumor, or radiation therapy, refers to limitations with jaw mobility resulting in failure to open, lateralize, or protrude the mandible. Trismus affects greater than 30% of patients undergoing chemoradiation therapy, and almost 40% of those who have had surgery and adjuvant radiation 6 months post-treatment. This can result in a number of speech and swallowing related issues. Our approach to managing trismus should be multimodal. We should include exercise, jaw mobilization with the devices as shown here, Botox, medication, and manual therapy. The literature does stress that exercise in isolation does not have a significant, meaningful impact on increasing jaw range of motion, and that multiple treatment methods should be implemented to maximize the efficiency. Utilizing ongoing assessment of swallow function, whether it be a clinical evaluation or an instrumental, such as a modified barium swallow or a FEES, is paramount in the head and neck population to ensure safe and effective swallowing. All of these things can be impacted by patient sensory impairments, so silent aspiration, the patient's altered anatomy, such as edema or surgical reconstruction, physiologic impairments in head and neck patients with dysphagia, which can include but are not limited to decreased pharyngeal constriction, reduced tongue-base retraction, impaired hyolaryngeal elevation and excursion, incomplete epiglottic inversion, and reduced distension and duration of the PE segment opening. Our clinical assessment should be completed pre-intervention to obtain baseline measures of swallow function, as well as conducted ongoing throughout treatment. Reassessment following treatment can also provide the SLP as well as the MD and the patient with information on swallow regression and improvements following radiation. Our options for instrumentals include modified barium swallow studies, or MBS, as well as fiber optic endoscopic evaluations of swallowing, or FEES studies. Both serve unique purposes. For instance, FEES can provide us with the direct visualization of the pharynx as well as the laryngeal structures, the ability to directly evaluate secretion management and assess for the presence of internal lymphedema, as well as evaluate glottic sufficiency. The MBS is valuable in that we're able to not only see the pharyngeal stage of swallow, as we do in FEES, but the oral and portions of the esophageal stage of swallow as well. MBS is also the gold standard approach in evaluating for any sort of leakage or any type of spasm or dysfunction of the tracheoesophageal tract in a laryngectomy patient. Here you can see a side-by-side view of both a FEES and a modified barium swallow post-radiation treatment. You can see on the FEES, we can assess for the edematousness of structures as well as direct visualization of secretions as well as residue left over post-swallow. And then on the modified barium swallow, you're able to see that narrowing and that obstruction of bolus flow. The SLP involvement in managing head and neck lymphedema is becoming increasingly acknowledged. We play a very important role in the assessment and management of head and neck lymphedema. As we know, lymphedema refers to the chronic swelling resulting from damage to the lymphatic system. When flow of fluid is disrupted, in this case due to damage sustained from radiation or surgery, it results in a buildup of lymphatic fluid and subsequent swelling. Evidence suggests that higher severity of both internal and external lymphedema result in more severe episodes of aspiration and poorer patient-reported outcome measures. A majority of swallowing dysfunction is the result of food and liquid pooling along the edematous structures unable to be moved into the esophagus. In this recent study, it is shown that while external lymphedema decreases substantially after 12 months post-treatment, the presence of internal lymphedema persists far beyond this at a much higher prevalence. It is very important to consider when assessing a patient with external lymphedema that they may be presenting with deficits internally as well. And it's important to ask pointed questions to decipher whether or not further intervention might be needed. We can ask if the patient is having trouble swallowing, if they're having difficulty managing secretions, any pain, discomfort, or tightness, or difficulty breathing. The SLP role in lymphedema management includes the implementation of manual lymphatic drainage, or MLD, advising the patient on the use of compression and bandaging to help maximize drainage, incorporating stretching and exercise, educating the patient on self-MLD sequences, skincare, hydration, and diet and lifestyle considerations to ensure effective management overall. As SLPs, we are perhaps most often looked to by our colleagues to assess a patient's aspiration risk. Aspiration is the term used to refer to the act of food, liquid, secretions, or foreign body entering the lungs. The most common consequence of chronic aspiration is the development of an aspiration-related pneumonia. And aspiration pneumonia has been observed in 24% of head and neck cancer patients treated with chemoradiation over a 5-year period. Outcomes from aspiration among head and neck cancer patients are much poorer, with reports of approximately 1/3 of those hospitalized dying within 30 days of admission. The risk of aspiration pneumonia developing is influenced by multiple factors, including a patient's oral health, ambulation status, level of activity, and underlying medical conditions, especially pulmonary compromise. Much of the recent literature has examined the correlation between a patient's cough strength and lung function with aspiration. It's noted that expiratory function in chronic head and neck cancer aspirators is significantly decreased. Therefore, we can hypothesize that improving cough strength and increasing the expiratory pressure will in turn reduce the risk of pneumonia in a head and neck patient. One of our newer therapeutic approaches when treating the head and neck cancer population is the use of expiratory muscle strength training, or EMST. This is a pressure threshold device in which there is a one-way spring-loaded valve, which will not open unless enough pressure is generated through expiratory effort, so blowing through the device. The device helps to engage the suprahyoid muscles and the submental muscles, both of which promote laryngeal elevation, which is necessary for clearing the pharynx during swallowing. Multiple studies have shown that increases in max expiratory pressure also correlate with improvement in airway protection and cough strength. And these are two separate studies that show, following an 8-week protocol, maximum expiratory pressure improved amongst the head and neck patients, and there were also significant improvements seen in swallowing safety and diet hierarchy. So it's believed that patients who undergo expiratory muscle strength training significantly reduce their risk for aspiration and can go on to enjoy a more least restrictive diet.
Another modality that we target in the patients with head and neck cancer are different areas of voice therapy. Intervention for these patients are going to be dependent on the etiology of the patient's dysphonia. Therapeutic techniques that can be incorporated include relaxation or breathing exercises, easy onset and frontal focus exercises, or hyperadduction tasks. All patients receiving voice therapy during and/or following radiation treatment also benefit from provision and review of vocal hygiene parameters, which review adequate hydration, vocal rest, avoiding vocally abusive behaviors, optimal posture, and adequate use of breath support. A unique population also targeted within the head and neck cancer community are patients status post-laryngectomy. In these cases, we're going to continue to target reduction in perilaryngeal strain via relaxation and breathing exercises, while also trying to improve diaphragmatic breath support needed for alaryngeal speech and voicing patterns. Alaryngeal speech can be completed across one and/or multiple modalities, most commonly tracheoesophageal voicing, esophageal speech, or with use of an electrolarynx. One of the most crucial aspects of continued maintenance and/or improvement in speech, voice, and/or swallowing function in the head and neck patient is continued incorporation of their home exercise program following discharge from speech pathology services. Speech pathologists must provide, review, and stress the importance of long-term radiation effects on the head and neck mechanism in absence of daily incorporation of the patient's home exercise program. With daily incorporation of exercises, recent studies have shown a significant decline in treatment or tumor-related dysphagia and dysarthria within the first 2 years of receiving radiation therapy when patients were able to adhere to their home exercise program. Here we just have a list of our resources for you guys, and we're happy to answer any questions that you might have. Thanks for listening.
Thank you very much, Daniel and Margaret, for that great presentation. It is now my honor and privilege to introduce our keynote to you all today. Dr. Nicole Stout is a certified lymphedema therapist, Senior Director for Survivorship and Wellness with the American Cancer Society, and an adjunct professor with West Virginia University School of Medicine. For significant contributions made to the profession, American Physical Therapy Association awarded her with Catherine Worthingham Fellowship. Thank you very much, Dr. Stout, for taking the time and speaking with us today.
Hi, everyone. It's really an honor to be here with you to share this keynote talk. Thanks for joining us. Thanks, Dr. Maltzer and your planning committee for inviting me to really talk to you about rehabilitation and how we work to embed rehabilitation as a core component of survivorship. My name is Nicole Stout. I am in a new position as the Senior Director of Survivorship and Wellness at the American Cancer Society, still maintaining my adjunct work at West Virginia University, but moving on to help to expand survivorship work around the country with the American Cancer Society. What I want us to think about today is, I know we're all rehabilitation providers, and of course we have and we carry that with us as who we are and how we function. But what I'm going to encourage you to think about is to step beyond just the cancer and rehabilitation clinic and think about how we really embed our services and conjoin ourselves with the mission of survivorship programs in our cancer institutes. Some of the objectives that we'll talk about today, we'll talk about using prospective surveillance as an approach and the supporting evidence base for that type of a model, and how we can really leverage that to help us integrate elements of that prospective surveillance model into cancer care delivery. We'll talk about some of the domains that we want to be thinking about when we're talking about implementing rehabilitation services into cancer care and how that will influence survivorship. And then I also want to share some insights and some strategies on community-based outreach for assessing and meeting functional needs in the communities where people live, work, and exist outside of the four walls of our Cancer Institute. I like to start off with a question every time I give a talk, and I think about us in rehabilitation, and I ask, when we know that there is a confluence of circumstances that will escalate the risk of an adverse outcome, are we proactive or are we reactive, right? In rehabilitation, we tend to be a little bit more on the reactive. Somebody has a problem, post-surgical, post-trauma, they come to rehabilitation to fix that after the fact. But in cancer care, we have an unprecedented opportunity to be more proactive in risk stratification. At the point of cancer diagnosis, we know with pretty good certainty what the treatment plan will look like for that individual over the course of about the next year. We know the treatments they will receive, the side effects they will experience mostly, and we have a good insight as to how that will impact their ability to function. So we should be thinking more proactively and more prospectively in how we manage these individuals through cancer care rather than waiting. And so from that premise, that was sort of the genesis of how we've seen the evolution of rehabilitation as a standard as it has been viewed by the Commission on Cancer. So in 2020, the new Commission on Cancer accreditation criteria and standards were released. And something that was new in this iteration was Standard 4.6, which made rehabilitation care services a criteria or a standard for accreditation of cancer centers. So the criteria that were outlined in this identified the need for rehab services and outlined a rationale. At this time, also, there was a new standard 4.8 that was released for survivorship programs, and it required that cancer centers develop and implement a survivorship program directed at meeting the needs that were treated of patients that were treated with curative intent. Interestingly, there was also nutrition services that were elevated to a standard. So in the past, having rehabilitation was one of those things that was nice to have, it was important, but now after 2020, these are standards. Cancer centers must meet these standards in order to receive accreditation. So if we dig into that 4.6 rehab services, really it requires that there are policies and procedures in place to guide referrals to rehabilitation services, either on-site or by referral. And really it suggested that the availability of rehabilitation services were essential as a component of comprehensive cancer care beginning at the time of diagnosis. That really is important for us to take a hold of and to think about how do we put ourselves in that position to be there at the point of cancer diagnosis and not react and wait for problems to happen, but to be part of that proactive solution. And I would say that this rehab services standard alongside the new survivorship program standards really could come together very nicely to give us that more proactive, prospective surveillance approach to integrating rehab services into survivorship. So where are we now with how are we doing with the Commission on Cancer 2020 standards? Well, just in time, we had a publication this summer that was released by a group out of the Commission on Cancer. They conducted a survey of COC accredited sites across the United States and published this article in July of 2024. They had 384 sites that responded. So these are cancer centers that are accredited by the Commission on Cancer, and you can see the distribution of the respondents here. The good news here is that these responses are reflective of not only comprehensive cancer centers, but also community-based cancer programs were well represented. So the survey really asked, what are you doing as far as services for cancer survivorship? What type of things, what type of personnel and staff are you using? And really, what are your perceptions on how it's being received? So the findings here, they looked at the survivorship program team members and percentage of program respondents. Very high percent of those team members included nurses and social workers, not surprisingly. Down here at the far end of the spectrum, though, you see physical occupational therapists much less represented, less than 50% of programs reporting that they had survivorship program team members that were PTs or OTs. So here's an area of opportunity, right? Some of the other things that were looked at were the clinical services offered. And you see pretty high numbers in the dark green there across the bar chart of clinical services that are offered available to all survivors on site or through referral. Tuck that into your mind because we're going to come back to that in a moment. And so you can see over 85% of centers said, hey, yeah, we have rehab services available on site or through referral, and very high offerings of clinical services across most things that we would deem important for cancer survivorship. However, and this is probably what we know to be true in practice, the perception of those individuals who were completing this survey around utilization, actual utilization, really perceived that only some, few, or no survivors were really receiving the services that were offered. So yes, we have the services. 90%, 85% of centers have the rehab services, but very few of them are actually connecting survivors to the rehabilitation services program. So this is a huge gap. And the two most common barriers that they identified in getting patients connected to the service were lack of referrals and patients not being aware of the services. So there's an opportunity here for us to position ourselves probably with a little bit more of a robust approach to insert ourselves or embed ourselves into the cancer care delivery system. Why do we still struggle here? Why are we struggling to meet the unmet needs? And really, there are some differences in alignment. There are some differences in definitions. I think we maybe don't speak the same language. We talk about distress screening among our patients with cancer. We talk about symptoms and symptom monitoring. We talk about needs assessment. And each of these things seem to mean different things, or are interpreted or perceived differently by different parties on the cancer care team. Symptom management doesn't necessarily improve participation or alleviate a patient's needs. If we manage a symptom like pain or nausea or vomiting or constipation, symptom management doesn't necessarily mean that that helps them return to work. It may not alleviate unmet needs that they have on the social support or economic front. Screening and assessment of any of these domains, stress, symptoms, needs, all of that needs to lead to actionable interventions to actually alleviate the needs. And so when we do something like a needs assessment or a distress screen, we really need to think about what does the individual actually need to help them overcome the barriers, meet the needs that they have. What services, what do we need to connect them to? How do we meet those needs? So I think there's a gap here in aligning and differentiating what these things mean, why they're important, and most importantly, really describing how can rehabilitation help to alleviate some of these gaps. So let's flip to that prospective surveillance model. Of course, it's one of my favorites. We're 12 years beyond the publication of the prospective surveillance model as it initially was created through a consensus organization group with the American Cancer Society. And really, this relies on utilization of a rehab professional from the point of diagnosis. So there's a pre-operative functional assessment that's done with the individual. And as they proceed through cancer treatment, there is continued interval reassessment. Really, we want to understand what's normal for that person at baseline. How do they function? What are the activities that they're involved in? And then as we monitor them through cancer treatment, how do those things change? Using this prospective approach, we're able to identify emerging needs, emerging impairments, and when we do, we can refer that individual for more intensive rehabilitation or support services to help alleviate those needs. This is an ongoing, repeated interval assessment that should really occur throughout the continuum of cancer care and beyond, because we know cancer is the gift that keeps on giving, and cancer treatments can carry side effects and late effects that may influence an individual really for the remainder of their life. So with this framing in mind, how do we actually embed and get our services to the patients who need us? So I think about that prospective surveillance model along the cancer care continuum at the point of diagnosis throughout the duration of treatment. When we introduce cancer treatment, the trajectory of function will change, period. The individual is very different functionally in 3 months, in 6 months as they move through cancer treatment. And as I said before, we have that unprecedented opportunity to understand what is the treatment plan, what are the common side effects, and so we can be a bit anticipatory in identifying when we might see the onset of impairment or the onset of symptoms, like peripheral neuropathy, for example. We introduce a taxane-based agent. We can pretty well expect that we're going to start to see symptoms consistent with neuropathy, sensory symptoms, motor symptoms throughout the duration of treatment. Why are we not screening and monitoring that individual proactively to understand how that influences their function? So we should be thinking about moving our intervention continuum using prospective surveillance, really from diagnosis, understanding risk, understanding how to reduce risk, and how to continually monitor, and then to triage to an appropriate setting when that individual in fact does experience the change that will negatively influence their function. Now, I'd also like to say, when I talk about function, I guess I would say I'm talking about a capital F. So it isn't just physical function. I'm talking about cognitive function, sexual function, psychosocial function. So really broadly thinking about the changes that occur that negatively impact the individual's ability to participate in their life roles. So some of the things that we have done in implementing a multidisciplinary, multi-specialty program that helps us to indeed get that baseline needs assessment. We obtain those pre-treatment measures. We've really surrounded the patient by a team. This is an approach that brings along perhaps a navigator, a social worker, behavioral therapist, any number of ancillary or allied health professionals that can help to support the individual. We do this at baseline using standardized tools, standardized screening and assessment tools, and we think about where do we set those thresholds for referral? When does clinically meaningful change exist? How do we operationalize this in our clinic setting, and how do we drive this based off of guidelines? So I'm going to take you through some pragmatic examples. There's really two ways that we could think about embedding rehabilitation, better engagement of rehabilitation services into cancer care delivery. One of those is really by enabling what we already have in practice, our EHR-based driven or EHR-driven screening and triage models really as an approach to early rehabilitation and early intervention. You walk into any cancer institute around the country, and I guarantee you that they are using some type of distress screening tool because, again, it's an accreditation standard from the Commission on Cancer that was initiated over a decade ago. So chances are they're using some type of distress thermometer, distress screening tool, some type of quality of life tool. So really understanding what is being used. Are there opportunities that we could identify subdomains within that tool that could serve as a trigger for rehabilitation? Is there evidence for cut points with the distress thermometer, with the SF-36, for example? And then what is our triage process? Can we use some type of electronic automated process for referrals? Can we enable outreach and telehealth to the patient when those issues are identified, rather than the arduous process of scheduling an additional appointment, getting pre-authorizations? Can we do some type of quick referral to rehabilitation for a consult to understand what the nature of the issue is? And then really understanding where we are with what needs to be further assessed based on what the patient tells us and what we see on that distress tool. So we've operationalized this in our cancer center using an EHR approach, and I'll just walk you through this, and I'll also guide you to the publication so that you can get a better look at the details. We've enhanced our distress thermometer, and based on the problem that the individual selects, there's an algorithm that we've built into our electronic health record that routes the patient information to through an in-basket message to what we call a provider pool. You see the examples of the pools here. So based on the categories within the distress thermometer, practical and family problems, emotional problems, physical problems, spiritual concerns, depending on the level of distress that an individual selects, if it's greater than or equal to 4, and the boxes that they tick that regard their specific problems, that will route patient information for review directly to the subspecialist pool. So we've created this opt-out approach. We don't ask the patient, well, you clicked this box that you're having family problems. Do you want to see a social worker? Because truly, that's putting a lot of burden on the patient, and the patient may or may not know what a social worker is, what they could do for them. Same with rehabilitation. So when physical problems are identified, we automatically route to the rehabilitation pool, where a group of therapists have developed a workflow whereby they review the patient charts and decide, hey, let's give this guy a call and see what's going on. Or, hey, this person's coming in for a visit in another day. I'm going to go touch base with them when they're here for their chemo infusion. So each of these pools are comprised of specialists within that field. They've developed their own processes and tracking mechanisms for reviewing and engaging with the patient. We also identified, though, although NCCN says 4 or more is considered clinically meaningful, we see a lot of individuals who report a distress level less than 4, but they've got a whole bunch of boxes ticked. And so when they identify 3 or more problems, that also is a trigger to route to each of those pools. Importantly, by putting the patient information in front of the specialist, letting the specialist get in touch with the patient, we've taken out an important burdensome step for our physician colleagues and our APPs. We've actually reduced their workload and their workflow in this by over 95%. So we've really taken and put the patient in front of the provider that they need to be in contact with and allowing that specialist to determine what should be the next best step in care. So we've enhanced our distress thermometer tool as well. The physical problem list was somewhat vague and a little bit challenging to inform our specialty care nurses, our social workers, and our therapists. And so you'll see what we've done is we've added some pull down boxes. These appear as pull downs that can be clicked or ticked in the EHR. So this is the physical category specifically. And this also helps just to give context to the individual in the pool who's reviewing the patient information. So we enabled this through our Cancer Institute. We enabled this, and we did a review of our patients in our distress category that came into the physical problem pool. And over the course of about 9 months, we were able to review nearly 550 patients. We looked at those that we categorized as mild, moderate, or severe distress. We looked at the type of problems that they were most commonly reporting. And interestingly, we looked at the demographics as well. Interestingly, across the problems, we see the same problems very common. Fatigue, nobody should be surprised by that, whether it's mild, moderate, or severely reported as distressing. The second biggest problem were changes in eating. And then the third were recent changes in memory and concentration. But the fourth, we got a little bit of a different view, especially in our more advanced distress patients with numbness and tingling, as opposed to ability moving around the home. So really, whether it's mild, moderate, or severe in the physical problem category, we saw pretty similar issues with fatigue, memory issues that patients were experiencing, changes in ability to move around, numbness and tingling, and then the eating issues that they were experiencing as well. So our EDT was really effective at identifying patients for whom physical problems needed to be addressed. Of the individuals that we reviewed who had physical problems that needed to be addressed, there were 70 individuals. About 44% of them had their needs addressed by our navigation pool. So they had checked a problem, they had not received any follow-up, and our navigator through the rehabilitation pool was the first person who was able to get in touch with them and help to address the need. About 23% had already received some type of referral for services, and a third we were not able to catch up with or get in touch with after several calls. And we did have a small number of individuals who denied that they had a concern, even though they had reported on that distress score within about the last week that they were having those issues. And so this was fairly feasible. It took anywhere from 10 to 45 minutes to complete the chart review and the patient engagement. So the chart review was a quick review by the navigator who manned the pool, reached out to the patient. Sometimes a phone call was 10, 15 minutes, and sometimes it was considerably longer than that, depending on the patient's needs. The volume of patients, though, that came into the pool far exceeded the capability of the 10% FTE that we had designated to oversee the pool. That was the hours per week that we had designated. So we presented this, and this analysis is currently in process, and we hope to have a publication out soon regarding the differences between our mild, moderate, and severe groups, and then how those problems were addressed with intervention by the rehabilitation provider. So enabling that enhanced distress score from the physical problem list really seemed to be effective at getting patients in front of the rehabilitation provider who had needs. And if we can do that again in a more proactive fashion, it helps us to engage the patient earlier before that unmet physical need becomes more disabling. Now, I've talked to you there about how we embedded or utilized our electronic health record to automate much of our process. Another opportunity that exists really for us to align rehabilitation services with our survivorship programs is to embed that rehabilitation professional on site for a consultation and or navigation services. And so this is a different approach. This requires us to have a staff member, a rehabilitation professional that is actually in the cancer care clinic, right alongside the physicians working there on a consultative basis. So when we think about how to embed some of the questions that we should be asking, how are we screening and determining who needs to see the rehab provider? Is that broad? Is it based on an impairment? Is it specific to the cancer type? Do we say, oh, we put a therapist in all of the lung clinics because we know that those patients have high needs? Or do we say, you know, the therapist is there and the patients complete some type of assessment battery, and if they trigger at a certain level, the therapist will see them. So we try to think about how do we best optimize that embedded service. And then triaging to the next best step in care. How do we establish a care plan? Can they bill for the services while they are there in the clinic? What is the frequency and timing? Do they have to get a pre-authorization and have them come back for an additional visit? Many of our patients who are in active treatment are coming in with some routine frequency to the Cancer Institute. So we want to think about how does that workflow, how will that workflow actually go? So the workflow for assessment and triage to the next step, how do we generate the referral? Who does that? How does it get signed in the clinic? And then how do we connect the patient to the best therapist to meet their needs? So really that becomes more of a consultative service. So there are a couple of things to think about here with this embedded care delivery model. This is the rehab provider co-located in the cancer clinic. This is a screening or consultative service. This is not PT evaluation or OT evaluation, 45 minutes to an hour. It's definitely a lower intensity intervention. It could be education, it could be exercise advice, it could be, hey, I need you to come back in for a more extensive evaluation the next time I see you, and therefore referrals then become generated to distribute patients based on their functional needs. And I'm just going to go through a couple of different examples with some evidence base for how this has been done. There are some foundational principles here, though, for embedding therapists in the cancer care delivery continuum. Really, we think about these models as being rehab clinician driven and PRO supported, patient reported outcomes measures. And we'll talk about some of the different PRO tools that are out there. But a patient reported measure is just that. It's the patient report of how they are functioning, what types of problems they are experiencing. And that should be a trigger to help to generate the referral or the connection to that individual who's embedded in the cancer care delivery continuum. So we embed a process into the clinical workflow, really based on the prospective surveillance model. We screen at repeated intervals. We identify functional deficits based on what the patient tells us in the PRO, based on what we then assess clinically. We stratify the severity of their need and decide on the next best step in care. Now, this may be a billable service depending on how it is structured, depending on the funding stream, depending on how the clinic is set up as the therapist is set up as a billable entity, if they have a schedule that is unique and can bill in that cost center. Or this is a downstream process of capturing more billable services in your rehab facility because that consultative service generates more referrals. Mostly what this does is it really creates a nice warm handoff between the providers and it helps the patient confidence. The patient feels like this person's on my team. They saw me in the cancer center. If I do have to go to a rehab facility, if I do have to go to an outpatient center, this person knows what they're doing. They're going to give me that warm handoff. So just quickly, I want to go through a couple of different embedded models that have an evidence base. The Huntsman Cancer Institute at the University of Utah had a really nice grant where they studied an embedded physical therapist in their thoracic clinic, specifically for lung cancer. They used the AMPAC, the acute measure of activity measure, post-acute, and they looked at staging patients based on their level of mobility and prescribing interventions for exercise based on those stages. They used the therapist here as a point of service consultation to engage the patient, educate them on their exercises, follow up with them about compliance and adherence to the exercise program, and really looking for any other impairments that existed. We've implemented a clinically embedded therapist in our brain tumor clinic. We embedded an occupational therapist alongside the use of a patient-reported outcome measure, the PROMIS Cancer Function Brief 3D. The Brief 3D PRO is a valid tool it is sensitive to change over time, and it may be useful in looking at predicting functional decline. And so we map our workflow for you here to see that alongside the medical oncologist, when the patient comes in for the clinic visit, the therapist has a co-located tandem open schedule with the neuro-oncologist, and the oncologist performs the assessment, reviews the PRO, determines if they need to be walked in to the OT schedule. The OT is there and provides follow-up to that screening with an intervention on site and or refers them to the next best step in care. Now, not necessarily just a funnel to rehabilitation. What we're learning in looking at the workflow of this occupational therapist is that they are referring to rehabilitation, but they're also referring to places like neuro-ophthalmology, home care services, as well as other services that may be needed by the patient. So just in doing and conducting that functional assessment, having that touch point, the occupational therapist has been able to identify other more expansive needs, bringing social work into the mix, helping to identify financial difficulties. So all of those issues and needs are being reviewed really in this short consultative visit, and the OT is navigating the patient to the right next best service. There is also a model for rehabilitation navigation using the navigation model that's very familiar in cancer institutes around the United States, embedding a physical therapist as the navigator, where they coordinate cancer care, but they also do so through the lens of functional assessment. And this has really been very beneficial in, again, helping to identify early changes in functional decline and getting that patient through the consultation with the navigator into the rehabilitation service. And you can see the workflow here, and there are several publications that I'll cite in the references that have helped us to move this navigation model forward. So we've talked about how do you embed into survivorship services really within the four walls of your cancer institute, but there's really something that we need to think about that, of course, is our communities. Not everyone can come back to, nor are patients very much willing to come back to the Cancer Institute just for that one visit with a dietitian or just for that one engagement in rehabilitation. So how do we really extend into the communities? And in order to do that, we need to understand our communities. So I'm going to share with you some thoughts on how to best assess what existing resources you have in the community and think about workforce development and building those resources that individuals with cancer need. We conducted a statewide needs assessment to understand patient, caregiver, and primary healthcare professional perspectives on unmet needs in our cancer survivor population. We used our state tumor registry and we mailed, surveys out to over 2,000 individuals. We used the Supportive Care Needs Survey, the SCNS, it's their short form 34. We had a 14% response rate. And the SCNS looks at unmet needs across 5 domains that you see here: physical, daily living, psychological, health information, support, and sexual. And you can see via this heat map, red and orange are the highest areas of unmet need, and we broke those out here based on type of cancer, as well as by the different domains. By far, the highest unmet needs were in the physical and daily living subdomain, followed by the psychological unmet needs. And so what we see here is the distribution by cancer type. But we took it a step further. We wanted to understand regionally where these individuals with high needs lived. Were they in some of the more rural areas? And so we obtained zip code as a part of the survey, and we did some cluster density analysis that you see here. So the clusters demonstrate some differences in our geographic distribution. Pink areas are high needs, high to moderate unmet needs, and gray areas are no or low needs. And so we look at the clusters, and you'll tend to see clusters like you do here in the areas where there are high population centers. Yes, we do have those in West Virginia and some of these areas here, but then you can see the pink areas really that extend beyond. So our analysis, our kernel density analysis told us there are significant differences in the pink areas where we have individuals with high unmet needs. And so we asked ourselves, is it about these individuals living in very rural areas, as sometimes we talk about rurality and lack of access to services. And what we found was there was a correlation, but it wasn't very strong. The light green areas here are the most rural parts of the state, and you can see the kernel density, the density clusters really clustering again in some of the rural areas, but not particularly. And then what we did was we looked at a social deprivation index, the social vulnerability index from the CDC. And this was where we saw very, very high correlation, high association with high unmet needs related to social vulnerability. So rurality is only one aspect of a driver of the unmet needs in these individuals. In fact, living in an area where you have poor socioeconomic status and you have other poor health indicators, such as poverty and overcrowding, those factors really were most associated with having unmet needs. And so we had to look a little bit further to understand what type of resources existed out in our communities. And so we conducted an environmental scan across these 4 quadrants. A lot of literature review, understanding what had been written in, published about chronic care management, primary care centers around the state. Unpublished literature or evidence we looked at. We did some qualitative focus groups with our primary care professionals and other community-based professionals, as well as with key informants, community leaders, and other individuals in the community, as well as patients. And then we also sought to really understand where in the state there are resources that are needed that could meet the needs of these individuals. And so by that we mapped and we looked for specifically where are the mental and behavioral health clinics around the state, where are our primary care centers, durable medical equipment. We had 15 categories that we looked at. And I'm going to show you a couple of these just so that you sort of get the idea. These are all of our federally qualified health centers in the state of West Virginia. And so you can see we have fairly ubiquitous coverage in many of these networks. They're really found in pretty decent density, and I've mapped over top of this where our high unmet needs patients were. And then we looked at our mental and behavioral health clinics, again, fairly well distributed throughout the state, even in the areas where we had high unmet needs. This maps all of our rehabilitation and exercise facilities across the state with pink and the green dot, or the red and the green dots. And again, there were a lot. There were over 220 rehabilitation or exercise and fitness facilities across the state. That's a lot of capacity. However, what we found when we did calls to each of these sites was they lack cancer-specific programs, and they lack staff that are knowledgeable about cancer-related morbidity. So the capacity is there, but we haven't enabled that capacity to work for individuals with cancer. So really, when I look at this final map that you see here, we do have we had 11 sites across the state, most of those at our cancer institutes or in large hospital systems where there was some type of a cancer rehabilitation or cancer exercise program. But really we have capacity. So we've got to be thinking about how do we engage those communities so that we can hand off our patients into the community to enable better meeting those functional needs. So I really think about this from a multi-level perspective. Capacity building and workforce development is critical here. Of course, we want to enable our patients and caregivers really thinking about how can I enable them to get the best care in their local neighborhood at home. We talk about being rural and driving long distances, and it is all very true that those are challenges to individuals getting access to care. But, heck, I'll tell you, I lived in the Washington, D.C. area for over a decade, and you drive 5 miles and it can take you 2.5 hours. That is a detriment as well to accessing care. So we really need to be thinking about strategies that allow us to bring our services to provide care at home. Sometimes that may mean self-management. How do we enable patients in self-activation strategies, behavior, intention, change in motivation, and moving them towards self-care and management. But also, how do we enable, from a health system perspective, allowing us to do better outreach through telehealth. Maybe we do better coordinated care and navigation into the communities. There are some nice models of peer-to-peer support. If we have an cancer exercise expert or a cancer rehabilitation expert, can we enable that person to do peer-to-peer coaching with local therapists in the community? Because the capacity is there, but they don't have the knowledge. So how do we create that phone a friend type of a process, and how do we get that paid for? In our communities, how do we set up resource guides? How do we conduct education and training? Those are a lot of the things for us to think about from a rehab perspective. We cannot expect these individuals to come back to our cancer center 2 to 3 times a week or even every other week for rehab services, when in fact there may be resources in the community that perhaps we can work to best enable. The social determinants of health, and this could be an entire other lecture that we could dive into, but really the social determinants of health have a significant influence on cancer treatment-related functional morbidity. Socioeconomic inequalities, we know, are related to the development of cancer. They're related to survivorship. They're related to comorbidities. Patients with low educational levels, patients with low SES really have poorer outcomes. And so we really need to be thinking about how do we better understand and assess these social determinants in a rehabilitation setting. They matter to us. Health literacy matters. An individual's financial means or lack thereof matters. If we're telling them they need to come back for 3 or 4 visits and they've got a $50 copay for each of those, are we inducing financial toxicity on top of what they're experiencing with cancer care delivery, which can be substantial? So I had the ability to partner with some colleagues in physical medicine and rehabilitation. We've really put together sort of a framework to help to guide therapists in thinking about how do we assess the social determinants of health? How do we strive to reduce disparities among individuals with cancer? I do believe, and we're working to obtain the evidence, but I do believe being co-located in the cancer institutes is quite helpful to reduce the burden of additional travel, additional visits, additional co-pays for patients. And so, it may be something that we really need to consider from a socioeconomic perspective, the benefit of that co-located service. So how do you get there? Just in the last few minutes that we have to talk, what are some of the ways that you can begin to enable your clinic, your setting, your hospital to really think through a process for implementation? And implementation is a key word there. I have done some training in implementation science. I would really encourage you to think about implementation science as an opportunity for you to learn a bit about the methods that can help you clinically in integrating these services. So we talk a lot about context and context assessment in implementation science. We have to understand the setting that we want to implement something in. So if we want to embed rehab services into cancer care delivery, I need to understand the practice context. I need to understand the barriers and the facilitators to implementing rehab there. I need to understand the culture I need to understand some of the process and mechanisms that maybe perhaps would be barriers and or facilitators. Once I understand that context, I can develop strategies to help me overcome and address those barriers and really come up with an implementation plan. So one of the first things that I really advise folks to think about is workflow mapping. It's not sexy, but it is so important. And in fact, there's evidence that suggests that when we fail to understand what the workflow looks like and we try to implement a new program, it is a significant point of failure. So understanding the workflow, what does that mean? How does the patient move into and through the clinic setting? All the way from when they call and schedule an appointment, what type of messages do they receive? When they walk into the building, where do they check in? Understanding how the patient moves through, where do the records come from? How is it aggregated? Who do they have touch points with? How are they roomed from the waiting room back into the treatment area? Who sees them when? And when we understand that workflow, we can really begin to look at where can we intercede with screening tools, more robust assessment, where is there time that we could engage with the patient during or after a visit, where can we collect and capture the data that we need. These are some of the ways that we could think about implementing not only patient-reported outcomes measures, but also just that clinically integrated service. So this is an example of a workflow that we mapped for the rehabilitation navigation model. These are some of the references I alluded to earlier. Understanding in the physical space of the cancer center, how did patients move through and get to the navigator? How did they move from the navigator out into the community? And then what were the factors that influenced the movement of that patient? The personalities, culture, the technical infrastructure that was available, adaptability, legal or regulatory factors that enabled or disabled the process from occurring. So once we understand those factors that influence how that workflow occurs, understand the barriers, understand the facilitators, we think about where can we intersect in this workflow. So our determinants that we should be looking at, I prefer to use the consolidated framework for implementation research. It gives us a really nice outline of 5 domains that we should look across to understand the barriers and the facilitators to implementing a new program into a clinical practice setting. One of the reasons I like the consolidated framework is that it maps very nicely and concisely into one of 73 different strategies that break out into these 9 categories that you see here. So based on the most commonly reported or highest ranking determinants, it can give us a prioritized list of the strategies that we should be thinking about that are known to help overcome those determinants. And then I like to think about how do we incite change? We have to use a multi-level strategy. As many of you can probably attest, one really incredibly energetic therapist with a really good idea is only going to go so far. We've got that individual level and they're very excited and they have the tools but if they don't establish the process at the clinic level, if they don't establish the regulatory policies at the health system level, the program is destined to be marginally or unsuccessful. And so when we map these things, we think about strategies that we would use to influence the clinic level staff. And by that, I don't just mean the therapists around you. What about your front desk process? What about your billing process? All of those things that happen within the staff of your clinic. Within your clinic, at the clinic level, how are your schedules set up? How are referrals generated? The healthcare system level, what types of agreements, legal, HR, role-based access to computer systems, how are those things set up? And how are they utilized? Those will all be important strategies that could help you to enable the implementation of a rehab model into cancer care. I put up a quote here from one of the individuals who participated in our rehab navigation implementation mapping, and she said executive level was absolutely 10 out of 10, most important. executive level support in the C-suite so that they understand how this is mapped to the organizational priorities of the strategic plan. Having physician stakeholders also critically important. So things to think about. It isn't just about us as rehab providers if we want to be a bigger part of that survivorship effort. So some key takeaways here, I think modeling your clinic workflow, who does what, when, you can certainly identify that, and then find out what the evidence-based guidelines are. If you're implementing a PRO in your brain tumor clinic, what's an optimal PRO to use in that setting? Create those pathways as opt-out so the connections are made. There's a nice warm handoff. You're not assuming, well, we told them they should follow up. We gave them a phone number. If patients are overwhelmed and they're overloaded, that warm handoff, that connection will be welcome. The community collaborations are really key, and they're going to become more so with a growing population of survivors. And then, of course, looking at outcomes and thinking about measuring what really matters. And I'll leave you with these thoughts. Because I feel as though in rehabilitation, we're so good at measurement, right? We measure the heck out of our patients. 6-minute walk test, grip strength, range of motion, sensation, balance, we've got it all. And we think a lot about functional performance. We think a lot about these rehab measures. But really, we have to think more about how we tie those measures and improvement in those measures as meaningful to the oncology care plan. Because my patient has improvement in balance, 6-minute walk test, in those rehab functional measures, does it change their prognosis? Do they respond better to their chemotherapy? Is their overall survival better? Do they tolerate their treatment? Do we have to do dose reductions less? So until we begin to tie our rehab outcomes measures to the important oncology measures, I think we still will languish in optimal implementation. The more that we can show by participating in rehabilitation, oncology patients do better. They have less treatment reductions, they have less hospitalizations, etc. We become more important and critical components as adjunctive treatments to oncology, to cancer care delivery. So in thinking about those program outcomes, this is from a recent publication, thinking about, again, that sort of multi-level approach. What could we measure as implementation indicators? What do we think about as clinical effectiveness indicators that we could think through at each of those levels? And I would really be remiss to not share with you one of my favorite rubric for really thinking about return on investment of a survivorship program. And I think this applies to rehabilitation as well. There's always something out of Dr. Catherine Alfano's work that's just always on the top of my mind. And recently it's this, because one of the questions we're being asked so frequently now is really, how do we get the business case or the business model to make the case for a survivorship program or a rehabilitation embedded program? And I think that Dr. Alfano and her colleagues in this paper really did a nice job of mapping these 4 domains of how we can show outcome that matters, how we show value in what we bring. It isn't just the number of patients that we evaluate or the number of RVUs we generate from a PT or an OT evaluation. It really has to do with patient experience, taking burden from physicians, driving downstream referrals, reducing burden to patients. All of those things matter as much as, and sometimes maybe even more, than how many RVUs or patients do we have through the door. So I think sometimes in rehab, we feel like we go into a tumor board meeting and there's all these really important decisions being made about the chemo and the immunotherapies and who's getting what radiation. And sometimes we feel like we're the little guys in the room, but I would encourage us to really take in the attitude of being the big guy in the room and bring that with us and really vehemently put that forward to help to make the case that rehabilitation is not only an important part, but truly an important adjunct treatment. And really, as we're starting to see now, even part of adjuvant therapy for individuals with cancer. So I'm happy to have been here. Thank you. And believe we take questions.
Thank you, Dr. Stout. That was really an amazing talk. There's so much to unpack here that I feel like I will definitely need to go back and rewatch this. My favorite thing that you said was that we're not the little guy in the room, even though that's what it sometimes feels like in rehab medicine and just in rehab services overall. But I think it's so important to remember that for our patients that have these functional decrements, that we're really helping their quality of life for the remainder of their life. So to see ourselves as the big guy.
Thank you, Dr. Stout. And at this point, we have a scheduled live Q&A session. So those who want to ask a question, this is the time for you guys to unmute your microphones. Welcome to turn on your cameras if you're able to, and ask our keynote any questions you guys may have, and then we will proceed with the final session, a quick Q&A with a general Q&A. So questions for our keynote first, please.
Thank
Dr.
you.
Stout, I have a question. I wanted to ask if you how you went about selling the embedding model of therapy services to cancer central leadership.
Yeah, that's an important target for you to keep in mind. It's great to go in, like I said, and have one therapist who's really gung-ho and excited, and maybe one physician similarly. But getting up the food chain really matters and really made a difference. I was hired in my cancer institute to do clinical research, not as a physical therapist, not to treat patients. But what I did was create these pathways to enable the rehabilitation and others supportive care services to come alongside the patient. So there was already a mindset in our Cancer Institute leadership. Our Vice President of Cancer Services was an incredibly important person. He held for us the dollars, right? He had the purse strings. The other person that was critical was the executive director of the Cancer Institute, who also happened to be a breast surgeon. So she had a little bit more familiarity with the benefits of rehabilitation. So those were two huge advocates. Because I was doing the research, publishing, creating these implementing these pathways, the research director of the Cancer Institute was also incredibly supportive. Many of these projects that I have published and have shared with you, we started many of these as a QI project with our Commission on Cancer. So that's an important engagement point. Each year, your Commission on Cancer is looking for a quality improvement project. And so the QI project is somewhere that you can intercede. I've been answering the questions in the chat, and you may have seen I said we just put a physical therapist in the radiation oncology clinic. And the reason we did that was because last year's QI project, 2023, focused on head and neck cancer and time to treatment. And we found a huge gap in giving patients exercises for TMJ and oral function. And so by virtue of us participating in that QI project, we were able to suggest, let's pilot for 3 months a physical therapist in the radiation oncology clinic. When is the heavy head and neck day? Which providers are there? And how do we bring that therapist in to do screenings? And I think I shared with you in there, we had a huge number over just a month and a half. We've had over 40 referrals that individual has identified and has sent on for rehabilitation services. So although she's not there billing the service, she is generating referrals to our rehab services. And in fact, our outpatient manager said, hang on, slow down. We don't have enough staff right now to handle this. And so they're looking at modeling for adding additional FTEs. So I think ideas around how do we pilot something is a great way to start. We got into the breast clinic because we got we had someone who was interested in SOZO, bioimpedance spectroscopy, and we were able to get a SOZO device through a donor who was interested in giving us the money. And by implementing that, we said we can't just let the surgeons run crazy and do this, right? You need to rein that in. We had the physical therapist then in the breast clinic. We started off just 1/2 day a week, and it quickly became apparent in the surgical clinic that the surgeon said, ho, 1/2 day a week is not enough. We need her here on at least all 3 of the days that our breast surgeons are in clinic. We had a grant to implement the occupational therapist in the embedded model, and that grant has since gone away. But what we have seen again with that occupational therapist embedded has been navigating patients again to the downstream services. The neuro-oncologist has basically said, don't you dare take away my OT. I need him here with me in every clinic, because the work that they're doing is so fantastic in addressing patients' need at the point of care. So I think it depends on where you have champions. It also depends on you building those champions at an executive level. Nobody pushed back when we said, okay, we had a successful implementation in the brain tumor clinic. We have now a model for how the schedule needs to be set up, what the front desk needs to do, what the MAs need to do when they room the patient, how we flex in the clinic. And so we took that to breast and we said, here's how we do it. And they said, great. So those are some of the ways I think about how to set up that process, think about creating parallel process across clinics. Where are there low-hanging fruit and opportunities?
Thank you for that response, Dr. Stout. I see one question in the chat. Diane Conlon is asking, what would be your patient report outcome of choice for the newly diagnosed cancer patient to see baseline function?
Yeah, so we've implemented, I put that in the chat earlier, Diane, thanks for the question. We have implemented the PRO, the electronic PRO, the PROMIS Cancer Function Brief 3D. And we did that because Dr. Smith's work and really the PM&R consortium that came together to look at the psychometric properties of that tool in rehabilitation and cancer really show us that there's predictive validity. So if I understand at baseline, I go through sorry, let me just say, the PROMIS tools were all developed by the National Cancer Institute, National Institutes of Health. So therefore, they are government products. They are free. There's no charge to use them. Many of your electronic record systems have them embedded already. We weren't using them in our Cancer Institute, but I went out and found that my orthopedic group was using the PROMIS tools. So the PROMIS tools embed what is called they use computer adaptive technology and item response theory. So it's a list of really over 100 questions, but the patient doesn't get 100 questions. Depending on their answer, it guides them to the next most logical question. So we're able to get an idea of what that person's function looks like at baseline with a validated tool that when we repeat that, it tells us a delta over time, and we can say, this is clinically meaningful. This is telling us a story that we're predicting that they are going to continue to decline. We need an intervention. The other piece of that, we learned this with the navigation pool. We've learned this in every aspect of implementation that we've done. You cannot just give patients the piece of paper and have them check the boxes. Some human being needs to come alongside them and talk about it and contextualize it and offer insights, gain insight from the patient, and work on some type of a tailored approach, because a lot of the times just checking the boxes is not going to really, and giving them some type of brochure is really not an effective mechanism. Now, is that the only tool? No. We've used the short physical performance battery as a clinician administered when we have the capability of having the therapist in the clinic, again, because we can look at clinically meaningful change over time. But what we're trying to do is scale that PROMIS ePro, the Cancer Function Brief 3D. We're trying to scale that across the entire Cancer Institute. We're working with our EPIC teams to try to launch that out to them before they even get to the clinic. This is what we've done in Brain. The patient schedules the appointment. How many clinic appointment reminders do you get? 20, 30, right? They blow you up. So we're trying to send that link ahead of time, get the patient to complete it so that it populates into the electronic record. The Proteus Consortium, I'll put a link into the chat. The Proteus Consortium is an organization that's come together and has developed an implementation toolkit for implementing patient-reported outcomes measures in oncology clinics. And they do that for research and clinical trials, but also for clinical management. So I'll put that in the chat for you as well.
Thank you very much, Dr. Stout. I know we are a little over time, guys. So what we'll do is we'll open it up for closing remarks from our course directors. Just prior to me doing that, just a big thank you to everyone who joined us this Saturday. And lastly, we will be emailing you the post-conference evaluation survey. And quite often we get a lot of recommendations from it, and we try to accommodate them. But also next year's Cancer Rehabilitation Conference, please think of topics that are specific to oncology rehab when you guys are providing your feedback, and we'll certainly make sure to incorporate some of your feedback when we pick topics for next year. So without further delay, let me bring in our course directors for their closing remarks.
I will just say that this was an amazing conference. I'm so grateful to everyone who helped make it happen. Very grateful to all of our speakers today. And I always say, you know, rehabilitation is a team sport, and it really makes a team to put a conference like this together and to really give excellent patient care and to propel our field forward. So I'm very grateful for that team.
Thank you, Dr. Martone. Could not have said it any better myself. Really appreciate everybody coming. I think this has been our best conference yet.
Thank you so much. And thank you all. Have a great weekend. We look forward to seeing you at our next event.